those who would like to continue in the panel, no problem. But we will begin our streaming at 11 o'clock. Chile time, 45 minutes, in order to continue with our agenda as set up for this third day of the second regional seminar on social development. And today we will be focusing on health. We have two very interesting panel meetings. The next, or the main presentation will be by Mr. James Fitzgerald. He is Director of Health Services and Systems of PAHO. So please keep connected, and we will resume the meeting in 45 minutes. And we will continue with the agenda. We regret the absence of Mr. Marmot. We were all looking forward to hearing from him. It will be for a future opportunity. Unfortunately, on this occasion, we won't be able to have him with us. Thank you, everyone. And those who were unable to join yesterday's session, everything has been uploaded to our webpage, our website, and you will see the link on the chat in order to see the presentations. Thank you, and we'll see each other in a few minutes. This is Christina Laudel. Can I disconnect and come back again? Yes, of course, no problem. 10 minutes before, yes. No problem, thank you for your patience.
Por favor, use el mismo enlace que ocupó para conectarse la
You
primera
need to use the same link you used to connect the first time.
Profesor Ortún, buenos días. Buenos días. Buenos días. Muchas gracias por su corrección y por su amabilidad por participar en el panel 4.
Thank you for your kindness, for joining and participating in panel number 4, where we will be hearing James Fitzgerald from PAHO. It is really a true pleasure to have you with us again. And of course, in all the issues that it's wonderful to count with your support. See you in a while.
Alfonso Chile.
Buenos días, profesor Ortún. ¿Cómo está?
¿Qué tal? Buenos días. ¿Cómo estamos?
Un gusto verlo.
No le veo la imagen, o sea, tampoco la identifico.
Soy María Luisa Mariño.
Hola, ¿cómo estamos? Es que hace poco me han ascendido a panelista, hasta hace poco solo estaba de espectador y de hecho ahora tampoco, en fin, tengo una visión limitada. A usted, por ejemplo, no la veo.
Estamos compartiendo, está la pantalla compartiendo el logo del seminario, por eso se ve limitado los panelistas.
La pantalla. Bueno.
Estamos y ya en 45 minutos nos vemos de nuevo.
Bueno, me salgo, supongo que después podré volver a entrar como panelista y si no ya lo diré.
Sí, por supuesto, por supuesto.
La aplicación Inspira no era tan complicada como parecía, ¿eh?
Qué bueno.
Recibí el mensaje, ¿no?
Sí, recibí el mensaje, ya le tengo el correo, se lo voy a enviar hoy día, así que muchísimas gracias.
Pues nada. Bueno, pues nada, hasta dentro de un rato.
Hasta pronto, gracias.
Vale, hasta pronto.
Hasta pronto, que esté muy bien.
Don Jorge, buenos días.
Buenas gracias, Claudia, ¿cómo
¿Cómo
está?
está? Bien, gracias. ¿Y usted?
Bien, también. Dígame.
Ahí está. Hola, muy buenos días, James.
tal?
Qué gusto
Buenos
verte.
días.
Hola María Luisa, ¿cómo estás? Gusto verte.
Muy bien, igualmente. ¿Qué tal? ¿Todo bien?
Bien, bien, bien. ¿Cómo está todo en Chile?
Todo bien, muchas
Animado, se
gracias.
dice. Bien.
¿Qué tal? Buenos días. Buenas tardes.
Hola,
o lo que sea.
hola, profesor.
Buenos días.
Buenas tardes nuevamente.
¿Qué tal, James? Buenos días, ¿cómo estás?
Alberto, gusto verte. ¿Cómo está?
Muy bien, muy bien. Con los últimos días de frío, porque aquí ya empiezan las buenas temperaturas. Supongo que allá en DC con muy buena temperatura todavía, ¿no?
Hoy fue el primer día razonable que hemos pasado por semanas de un infierno, ¿no?
¿Razonable con 30 grados o razonable con
30,
qué?
por lo menos a 30, ¿no? Y no 35 y 38.
Claro, claro. No, muchas gracias, James, por participar de este seminario regional y estar, digamos, en este panel y todo el apoyo que nos han dado. En la tarde va a estar Ernesto, estuvo en el inicio la doctora Etienne, ha estado saliendo bastante bien, ha estado fluyendo. Ayer tuvimos un día conversando sobre sistemas de pensiones, bien interesante. Y bueno, hoy día tú inauguras hablando sobre sistemas de salud, así que muy bienvenido, James.
Muchas gracias, Alberto. Realmente un gusto, siempre un gusto verte y trabajar con ustedes. Esta asociación OPS CEPAL durante la pandemia, yo decía, ha logrado muchos productos muy positivos, ¿no? Durante este tiempo, ¿no? Y un gusto también estar con lo demás también en el panel.
Perfecto, perfecto, estupendo. No sé, María
Alberto,
Luisa, si está Daniel. ¿Sí?
Está allá. Está Daniel,
Sí,
sí, está
acabo de
conectado.
entrar. ¿Cómo están? Un gusto de saludarlos a todos.
Hola, está Daniel. Fantástico.
Hola,
Hola.
hola
Bien,
Alberto, ¿cómo están? Hola a todos.
hago la posta, usted, profesor, queda a cargo, digamos, de todo el panel. Y muchas gracias, Daniel, por
No,
ayudar y
encantado,
apoyarnos en el
encantado.
seminario.
Gracias,
Muchas
gracias por la invitación. Muchas gracias. ¿Cómo están? No sé si no. Hola.
Hola, Daniel, ¿cómo estás?
Hola,
Hola,
James,
Jim.
¿cómo estás? Gusto de
Muy bien.
saludarte.
Igualmente, muy bien.
¿Cómo va todo?
Muy bien, muy bien.
Qué
Aquí
bueno,
muchas cosas como siempre, ¿no? Como ustedes.
qué bueno. También supongo que está Asa, Cristina.
Sí, Daniel, hace
Hola.
Cristina se conectó. Hola, buenos días.
Hola.
Se había conectado anteriormente, ya hizo las pruebas de sonido, pero se desconectó momentáneamente, ya va a regresar.
ok.
También tenemos conectado al profesor Ortún y a
Ya,
Linshia Bahia. También está
perfecto.
conectado
Y
ya
Camilo va a
con
entrar a
nosotros.
las 12, me dijeron.
Y Camilo va a entrar un poquito más tarde, efectivamente.
Efectivamente. Entonces estaríamos todos coordinados. Muchas gracias a todos por ya estar en la que llaman aquí la sala de espera digital, no sé cómo se llaman estas cosas. Y tú nos avisas entonces.
Sí, yo les aviso en unos 5 minutitos, yo creo que ya podemos partir para partir en la hora. ¿Ya?
Perfecto, gracias.
Muchas gracias.
Empezamos
Daniel.
la grabación a las 11 entonces.
Eso. Sí, por hay que avisar.
Ya por el tema del streaming también para avisar que
Nosotros
lo dejen corriendo y todo.
te avisamos, Jorge.
Muchas gracias, Zeta María.
No, gracias a ti. Jorge, si se pudiera iniciar el streaming
Ya
para
voy a,
comenzar en unos 5 minutos.
ya voy a avisar que comiencen el streaming.
Perfecto, muchísimas gracias.
A usted.
¿Qué significa para nosotros que todavía nos dan la palabra en 5 minutos?
En un par de minutitos comenzamos, exactamente.
Ya.
Gracias, Daniel.
No hay.
Presente Christina Laudel.
Buenos días, doctora Laurel. Mucho gusto
Buenos
verla. ¿Cómo
días.
está?
Pues aquí desconcertada. Yo iba hoy a Suecia y me acaban de suspender el vuelo, entonces estoy tratando de conectarme con qué va a pasar conmigo. Entonces, pero ya
Bueno.
estoy con ustedes por lo pronto, ¿eh?
Mucho ánimo. Le presento a Daniel Titterman, quien es el director de la división de asuntos de la división de desarrollo económico de acá de CEPAL, que va a estar llevando la moderación del panel.
De
Hola,
acuerdo.
encantado de verte. Y espero
Buenos
que se
días.
resuelva el problema del avión, del vuelo.
Pues sí, lo que pasa es que parece que hay un caos total en los aviones en Europa, ¿eh?
Sí. Ahí están con problemas los aeropuertos.
Así es. Bueno, muy bien, ya por lo menos estoy presente con ustedes, así es que a sus órdenes.
Muchas gracias. En 2-3 minutos empezaríamos la sesión, que primero va a ser una presentación James Fitzgerald de la OPS y luego vendrían ustedes con comentarios de 10 minutos, según lo tenemos
Así es.
estipulado.
15, ¿no?
15,
10,
yo no tengo
15.
problema, a mí me habían dicho 10, pero pueden ser 15.
Bueno, lo que sea, yo voy a, de cualquier modo puedo
No,
hacerlo
está bien, por mí no hay
largo,
problema.
Bueno, gracias.
Buenos días a Cristina, ¿cómo estás? Habla James.
Muy bien, ¿cómo estás?
Bien, bien, gusto verte de nuevo.
Sí, muy bien. Estamos ya listos todos para escucharte, ¿no?
Bueno, me alegro.
Daniel, si quieres ya podemos partir, ya están todos los panelistas conectados. Muchas gracias.
Entonces empiezo. Gracias.
Voy a comenzar con la grabación entonces.
Gracias, Jorge.
Gracias. Bueno,
Well,
bienvenidos.
welcome. Good morning, still good morning to this fourth session or panel of the seminar on social security and protracted crisis and opportunity to combat inequality within the Latin America and the Caribbean. This panel number 4 will discuss the subjects related to the health sector, structural challenges we have in the health sector in the region, and then what COVID or the COVID pandemic has meant and has led us to go deeper into the structural problems and also impose new challenges on the table. And from a future perspective is where should health systems move towards in order to face the most structural dynamics of the problems that we have faced in the region for several decades, and also think how is it that we must move forward to build more resilient health systems in order to face future pandemics. The dynamics of health sectors of Latin America. Unfortunately, we live in segmented systems, fragmented, segmented population systems, either by formal, informal, payment capacity, non-payment, free choice, non-free choice. In general, they are very segmented systems, either due to access of demand or supply or demand. And one of the challenges, if you are thinking, and this is one of the topics of the panel, of how to move towards universal coverage and resilient systems, how then the different supply structures, public, private, social security could be integrated with the different demands that come from people that on the one hand have social insurance, private insurance, or practically no insurance, and therefore is in the public sector. And there, the challenge is how to devise future health systems moving towards universal coverage. And before recognizing our distinguished speakers, we have also another topic, and that is epidemiological and population transition experienced by our countries. The epidemiological and population transition that has made chronic diseases to be of greater importance for the demand for health services, and thus how can we integrate primary health care with hospital, second or third tier hospital service, how to integrate them. Chronic diseases, first you need to have prevention and maintain or control to avoid them progressing. So the challenge is, how are we going to articulate the different supply segments, different rationales of demand, and we will be addressing the challenges involved in population and epidemiological transition in all of our countries. It's not a minor endeavor. And to discuss all these topics and how to move to universal and resilient systems, we have an outstanding, renowned panel. I will introduce first, we have James Fitzgerald. He will give us a 30-minute presentation. He's a great friend and is the Director of Health Systems and Services in the Pan American Health Organization, PAHO, Regional Office of the World Health Organization in the Americas. He oversees the PAHO WHO work program in health policy and governance, health systems, services organization, health workforce, financing in health research and access to medicines and health technologies in the region of the Americas. I will not dwell on the very long and resume. He has a PhD in pharmaceutical sciences and Trinity College Dublin. He is a member of several professional associations and advisory groups. James is a great friend and has a long-standing experience in health systems in Latin America, so he will make a presentation. And then we will have comments. We will start with Christina Laudel. She's medical doctor from the University of Lund, Sweden, Master in Public Health from the University of California, Doctor in Sociology from UNAM, Mexico, and Doctor honoris causa from the University of Buenos Aires, Argentina. She has a broad experience in national health systems, research activities in health areas, and he was an assistant secretary of the government of Mexico. She is the author of 18 books and 100 articles and of this area. She has been temporary advisor to PAHO WHO for the region. So it's a pleasure to have you, Christina. Then we have Linshia Bahia, Associate Professor of the Federal University of Rio de Janeiro. She has a degree in medicine from the Federal University of Rio de Janeiro, a master's degree in public health from the Osvaldo Cruz Foundation, and Doctor of Public Health from the Osvaldo Cruz Foundation. She has experience in the field of public health with an emphasis on health policy planning, mainly in social protection, health systems, public-private relations in the Brazilian health system, health insurance and market, health public. Then we have Vicente Ortun. He's Professor Emeritus He is Dean of the Pompeu Fabra of Barcelona, of Pompeu Fabra University, former Dean of the faculty, founder, former director, and principal investigator of the Center for Research in Economics and Health, Award for Knowledge Transfer, member of the governing councils of UPFF and the Parque de Salud Mar Consortium. He has long-standing experience, consulting experience in all of these subjects, so we are so pleased to have him with us. And finally, Camilo Cid, he is director of the FONASA system of Chile. Camilo has a PhD from University of Essen in Germany, and before assuming the FONASA, he was Officer of Social Affairs and Regional Director in ECLAC, and has also been Regional Advisor to PAHO and WHO with a long-standing experience, and was appointed by President Bachelet as an executive secretary for the Presidential Commission for studying a new legal system for health in Chile. He has a vast experience. Without further ado, then I will now recognize James for your presentation. Now, the floor is yours, or the screen is yours, rather. Thank you. I wanted to thank you for this introduction. You have already presented the challenges we are to face. A pleasure to see you again. Also, greetings to Christina, Linshia, Vicente, and Camilo. We met some time ago. Alberto, Maria Luisa, who are also connected. To all colleagues, hello, who are in this session. It is an excellent opportunity and presenting the context of health systems in the Americas. Within the context of what has happened in the recent years. And also, it has been a more structured, universal view of what could happen in the region. So I will begin with a brief analysis on where are we now in September 2022, having gone through 3 complex and difficult years in the region of the Americas, where the region has witnessed waves and waves of COVID-19 contagion, and with many, many deaths, enormous impact as to morbidity, mortality, very high mortality in the region. And the region of the Americas is the WHO region that has had the largest number of infections and direct deaths linked to the pandemic. Also, the impact on health, human resources, of course, that a tremendous impact. They've paid an enormous account associated to the communication of the virus and disease. Has affected millions of people in the region, as we have seen. Data presented 10 years lost as to progress in social development in the Americas. We estimate that the impact on health, we are losing 20 years in health results. All of this associated to the impact on the provision of social services in the region and the impact of COVID in the homes, in the households, access to health, access to work, to education, to the well-being of the population, and also the tremendous health, mental health impact. And so we are in a region that is recovering, yes, but what we have seen is that the pandemic continues with important impacts on the organization and capacity to provide essential services to the population. PAHO has, during these 3 years, with the participation of countries, it has measured the capacity of what we call essential services, those services that are necessary to respond to primary health needs of the population. Chronic diseases ranging to immunization.
These are services that are essential regardless of the efforts made by countries in order to maintain the capacity of health systems for the population. And the last survey was held in December of last year, was conducted in December of last year, and we were able to notice that 93% of countries responding this survey reported a certain level of interruption, in some cases quite important, with regard to the provision of health services, and 55% of the 66 trace services that were assessed presented some level of interruption. Now, what this implies is a context whereby people continue to seek care when the system doesn't have the capability in terms of responding to these needs. And we are extremely concerned with the impact that we will see not only today, but also in the future with regards to mortality, excessive mortality and morbidity in the Americas. In addition to that, before the pandemic, we are very aware, and Daniel already mentioned the existing barriers that we have in terms of the organization and structure of health systems, barriers associated to the segmentation of health systems, barriers associated to financing, to expenditure, barriers that are intercultural in terms of the system, the ability of the system to cater for needs. And we have also seen that the pandemic has identified these barriers, especially in the most vulnerable communities in the region, and therefore the association between interruptions in the provision of services and living conditions, social conditions, and health are even worse as a result of the pandemic. So what we are observing that several sectors on the side of demand, and also in terms of supply and of demand, have evidenced interruptions, and associated to this, we also see a drop in the care services in countries, and practically 70% of countries have reported that they have had to shut down certain services and even shut down health centers located in communities to provide service to the community, and therefore there is a significant increase in terms of the prevalence of needs to provide care that have not been provided as a result of the pandemic. Now, the situation was not completely negative before the pandemic. In 2014, countries in the region of the Americas adopted the strategy aimed towards universal coverage and universal access to health, and we call this universal health. And at present, at that time, we held significant debates about the meaning of health in the region, what coverage means in terms of the allocation of resources, conditions, and capacities of the system in terms of, in order to respond to health issues. And countries said, well, coverage is important, but insufficient. What we need is to improve access. Access is not only implies not only services but also financing, and countries established a goal for themselves, saying that they were going to spend 6% of the GDP for health expenditure, and we are noticing that countries have not, on average, have invested 2.9% in, and up to now 3.5%. And many countries are improving better in South America than in Central America. And associated to this, there has also been a reduction in expenditure. If we look at the data that we have in terms of public expenditure on health associated to the expense of people, we find that governments find it very difficult to achieve equality in terms of the provision of services. And we have a few countries that have achieved several goals, the goal of 6% of public expenditure with 20% of pocket expenses. We are progressing, but we haven't yet achieved the goals that we want to achieve. And how are countries spending their investment in health? Investment during the first in primary care are insufficient. The average that we have analyzed using several methodologies and overcoming the difficulty of measuring this dimension, we estimate that around 25% of public expenditure is allocated to primary care, and this is inadequate, insufficient in order to respond to the need of the population where they live, to respond to communities where they live in order to achieve comprehensive care. And this is a fundamental element that we must deal with now and in the future. James, I apologize for your presentation, but your image has disappeared. We see the screen, we see the presentation, but we can't see your face. I think I'll continue, and then I can resolve the issue of the camera. Yes, please. I apologize for the interruption. So associated to adequate investment, there is a chronic deficit of human resources for health. We estimated that the gap in human resources for the health sector is between 600,000 and 2 million people. Regardless of the methodology, these are very significant figures. And this, talking about doctors, nurses, midwives, dentists, pharmaceuticals, and leaving aside all the other human resources that are necessary and all the enabling conditions that are necessary in order to ensure the operation of the health systems. In addition to this, the location of these human resources is primarily in the second and third level of care. They are not working in primary care, where we need more people, equipment in rural areas that are not catered for. And those are major challenges for the health system. There is a lack of matching in terms of human resources in the region of the Americas in the design of health systems and the location of these human resources in the centers which concentrate greater technology, and therefore associated to the COVID-19. What has happened? Well, we see this inadequate distribution of human resources, because what has happened that countries faced with the pandemic had to reallocate human resources to the second and third level, especially hospitals, expanding to a very significant degree the hospital capacity, especially in ICUs, by 300% in the region. Associated to this, there is a lack of adequate human resources to ensure essential services in the first level of care and comprehensive care in integrated networks. And associated to this, we had a very big impact in terms of the human resources that we have. Apart from the distribution, labor working conditions are difficult. There is a lack of equipment and specialized personnel, especially at the beginning of the pandemic, with situations of violence and harassment within health services themselves, and of course the challenges associated to the availability of vaccines for human resources working in health. We faced stigmatization and discrimination in certain services of human resources, and subsequently a tiredness on the part of human resources, and we're losing indeed many human resources as a result of this. When countries need even more and seek human resources to incorporate them into the system, and honestly, what is happening is that we are losing a very important resource in health systems. Likewise, we also faced a context of a lack of supply and unequal distribution of vaccines and other other health technologies. And ECLAC has studied this situation very adequately at the beginning of the pandemic, and the import of pharmaceutical products and vaccines and other types of health technologies from outside the region. And the problem here is that there is a vulnerability in the supply chain. If the region if we already face significant problems whenever we face health emergencies, the region simply doesn't have the capability to respond to this. And this geographic concentration in productive, in value chain, in productive value chains in terms of vaccines and technology and so on is one of the major challenges that has to be faced by the region. And talking about the prior transformations that we have seen in the region over the past 10 years, we haven't experienced significant transformations and fundamental transformations in the Americas. These are all transformations before the pandemic and that were incremental in nature. Reforms focusing on care, models of care in order to expand access to certain levels of care, or reforms focused on assurance. But what we needed was comprehensive reforms that capture both elements in order to overcome coverage and effective access to all the population, to the whole population. Last year, when countries participated in several dialogues conducting this context analysis in the directive board of PAHO, we adopted a new strategy for the establishment of health services that are resilient and focusing on the issue of recovery during the stage subsequent to the pandemic in order to maintain, recover and protect public health achievements. And this calls attention to or focuses on four fundamental elements for the system. First of all, the need to conduct a substantive transformation of health systems in order to, with a vision aiming at universalization, primary care, strengthening leadership and governance, and emphasizing the renewed essential functions of public health. They also called attention to the need to face the challenge of the fragmentation of health services, the lack of access, lack of comprehensive care in order to strengthen the capabilities of the networks of health services and to improve the preparation and response to public health emergencies, and as a key aspect of financing and of the social aspect, to increase and uphold public financing of health, including measures aimed at tackling social determinants, environmental determinants, and economic determinants of health. And therefore, I want to analyze these elements in the proposal that was agreed on and what is happening based on these proposals in our region. If we look at the context of the transformation of health systems, what we can see is that there is a new approach to governance and effective leadership of these processes, a new approach of transformations focused on the principles of integration, facing up to this segmentation that exists in the system, and also adding and making progress towards the universalization of access to health, and based, of course, on the principle that everyone has a right to health. These transformations are now being viewed in a different manner in order to protect the population, expand access, and ensure their rights. Now, I wanted to present what is happening in some countries at present with regards these transformations. And this is simply a selection of some countries of South America. And of course, we have a lot more information about what is happening in North America, Central America, and also in the Caribbean. But if we focus on this, there are several countries that are presently adjusting a system of profound reforms of their health systems, changing the basis of their organization based on the right to health, and also advancing very adequately with social concepts such as the universalization of health and breaking down the barriers that existed with regards financing, human resources, administrative processes, and the fragmentation of the organization of services.
Very important progress, and what we're showing is that countries are setting priorities, and that's important because we don't have much time, and it's important to resolve some of the deficiencies, systematic deficiencies in the health system as soon as possible. Many of these transformations are based on primary care, and not only at the first care level, but with a special approach on primary care to recover in the short term and to face this more excessive mortality and morbidity wave. And we are going to see what can be done to ensure the capacity to provide the necessary care to the population, to the different communities, and promote and resolve the inequalities that we have seen during the pandemic. That require a high investment at the first, the primary care level to the people, community, and social determinants for health. It is really important that countries renew this commitment to the primary care, and you are all invited to continue participating and implementing in the pact for the APS 30-30-30, when we are requesting the countries to make substantial changes prior to 2030, allocating more resources to the primary care, and so destroying these barriers that exist at this level. Another aspect has to do with something very clear, that the health systems in the region have been designed to provide diagnosis, palliative services, but it is really evident based on what has happened with the pandemic that we need other approach, that we need high integration of principles, values in the functions of public health, in the transformation of the system itself, not only to accelerate the diagnosis and corrective services, but also prevention. We, in this moment, are in the process of supporting the different countries in the analysis of their own essential functions of the public health system. We have 10 countries involved in this process, and if we apply the cycle of policies and where we approach the development of these policies and we measure access, there are a lot of images getting out of here. And it's important that the countries update their own policies and by incorporating different elements in line with the social community needs. It's important to produce information, reliable data to improve better access to health and also financial protection. There's no greater approach in terms of development policies, but regulations to ensure high equity in terms of resources allocation and the process to ensure these services. As long as we implement this transformation and we put resources which are necessary, that means to have dialogues with the ministries of finance, with economists, to convince them that investment in health is investment in social development. Something that I mentioned before in terms of access to health technologies. this transformation in the region is something that is, I would say, a new way of understanding the importance that the regions of the Americas cannot be remain in the current situation with not enough development. So there are enabling conditions here which exist in the region with comprehensive policies, science and technologies, with institutional mechanisms for coordination. We have also an important industrial base with the pharmaceutical sector, which need to grow more. We have at the academia also, which is unfortunately fully scattered, but we have a network of different entities, people. I mean, we have different, regulatory authorities, and the last year, the countries of the organization have adopted a new policy to increase the production capacity, to increase and organize national policies between policy, science, and technology, to develop projects based on health needs, and to improve the regional cooperation to this. Together with ICLAC and others, we have undertaken different initiatives, and now we are making progress in this region. And the initiatives as Mercosur, was CELAC, PROSUR, important initiatives which are adding not only resources to the region, but knowledge as well. The technology transfer processes in terms of vaccination and throughout the Americas. And there are a lot of studies, ongoing studies, to analyze what has happened and what we can do to avoid repetition of the situation and to increase the productive capacity, especially in line with vaccines, which are absolutely necessary in a context of health emergency as the one we have gone through. Then, to face the situation related to health services access, well, we need to have a robust approach to these aspects, especially access and comprehensive care. So, based on this, the minister requested PAHO to work on new policy approach to integrate health services, which this was presented, is going to be presented in the Pan American Conference by the end of this month. So this is to face challenges not only in terms of emergency, but during normal times as well, to ensure care and resolution of problems related to population's health. That means that we need to increase the resolution capacity, to create networks, the approaches, comprehensive approaches on healthcare by organizing the different specialized services. There is a lot of experience here, but rather isolated, and we need to gather and put that information together by expanding the structural capacity of these networks in the different countries. Digital transformation is another aspect. Digital services are essential to mitigate some risks. Some situations, specific situations during the pandemic is not the solution, but provide access to health care, and it's part of the solution. We need to reorganize information systems, which is also part of the response that we need to put emphasis on. An element that was was a key element in the discussion with the ministers and the countries in the context of that we're living in was the articulation of public policies for the different resources with the organizations and network corporations, human resources, information systems, drugs, technology, health technologies, etc. So I wanted to tackle on two important things. It is essential that we focus on a comprehensive approach to ensure the services that not only has to do with integration to increase productive capacity and improve the quality and efficacy of drugs provision, but this is related to processes of different elements for evaluation of the health services. We now see an increase, a proliferation of new technologies with important expenses for the countries, especially pocket expenses that can represent in each country. So one comprehensive approach in terms of regulations and selection of the use of these elements is very important. And the pharmaceutical services, also an integration of these services to comprehensive health network is essential. As PAHO, as you know all, we have 2 rotatory funds to promote solidarity, and we think that this will continue and will expand the impact of that having that these funds are having on the different countries. As I mentioned before, the investment in human resources is essential. We haven't had enough human resources, so we need to analyze what we need from now on. It is important that the countries can reinforce the number of human resources in an equitable manner at the different levels, in the different areas of the different countries. So our regulatory framework are also essential, and accreditation, continuous education. If we want to improve the quality and capacity of the authorities, we need to think of these aspects, and then to ensure what we have and to attract more human resources. What is the implication of this investment in this effort focused on health and primary care, essentially? At the PAHO level, we have a powerful tool that has been developed during the pandemic, and we have then developed the virtual campus of the PAHO, which has increased a lot of emphasis in put during the pandemic. We have more than 1 million participants during the pandemic, and we can see here when this was born at the beginning of 2020, and the participation of healthcare workers here. We provide more than 26 courses related to COVID-19 to more than 3 million workers in the regions of the Americas. And so if we analyze a little bit more the profile of users, most of them are nurses, but we also have students of health sciences, which have been also included in the 12%. It has been Africa, Asia, which have been participating also, and we need to analyze much better to have more participation of healthcare workers at the primary care level. Over the last summit of the Americas in Los Angeles, the United States, in front of within the context of the pandemic, we have invited the countries to participate in a new initiatives. Now the work we are building with the countries of the region that is related to the efforts in health that had been mentioned. The idea is to close the gaps that we have identified according to base the health care models that had been developed by PAHO. We're going to strengthen the virtual school for public health, increasing the capacity of public health with the essential functions of public health, and strengthening the leadership program. The critical factor in the pandemic has been also leadership. If we don't have the appropriate leaders to manage emergencies and manage the transformation processes, we're not going to have a health system that is fully robust, properly built, and according to the needs of the different users. So we are going also to create a consortium of university in line with requirement of licensing in the Americas, and the process of education and knowledge of the workers is really essential. And finally, public funding. What is important here is equity, solidarity, and social protection.
Los mensajes son
I
claros.
think messages are key. We need greater public financing with greater solidarity and greater equity and sustainability. We know that we are in a complex fiscal context in the region, but it's important that in this context, we protect what we have, and if not, assign more, allocate more to be better prepared for future emergencies and ensure universal access for the population. This involves studies, space, fiscal space, strengthening context, effective monitoring of the financial protection. A key area associated to public investment would be the management, effective management of the budget, and at the same time, payment mechanisms of the providers aligned with the health system and its objectives. We call for having a greater investment in public health, in human resources, and the implementation of the RSI. And prioritizing the investment in primary health care, improving efficiency in expenditure, have a better selection of products, of medication, technologies, and consolidated procurement and regulation of private providers. All this calls for intersectorial action to improve social protection and interdependencies between health and economy. I will conclude with final comments. Some messages that can be of interest to reflect in these four. Or today more than ever is the time for effective transformation towards universal health. There is a window of opportunity. We need to make sure that we are ready to respond to the lost achievements, recover them, and improve them for future emergencies. It is a critical moment for technical cooperation among all of us in order to accompany this transformation. Also recognize that transformation will not be overnight. We've seen in Chile that the national health system is 70 years old, and they are doing now deep transformations of the system. But it's also other countries have 30 years. We need time, state policies, commitments from the population, demands from the population for better health and a system responding to these needs. Therefore, we need to strengthen governance. It's a key access in order to have better strategic management and better management of change of these transformation processes, involving greater integration of program priorities of health systems with a model that is primary care based. Policies and systems need to be strengthened, integrated, and responding to the needs of the population. Also, medication production policies, human resources, we need to adapt them, expand them to respond to the transformations we are going through. And we continue with advocacy to improve financing for health with greater solidarity, equity, and social protection. This is key if we are to sustain and support the change for the future. Thank you very much. Hopefully, I met the time allotted. Thank you, James, for an excellent presentation and overview of all the challenges of health systems in the Americas from the perspective of human resource and provision of services in primary health care, and to more complex services and challenges of financing. You've raised several relevant topics. One is to explain the idea of universal access. Universal is at stake at the end of the day, and also raising the issue of solidarity in financing, and have rather a view of how to generate necessary mechanisms in order to develop a solidarian system to move towards universal access. Also, urgency. We need to accelerate actions in that direction. It's important because the perception is that the gaps, the problems, waiting lists, lack of access, all that accumulates in time, and it's ever more difficult to address them. Therefore, priority is to accelerate the process, and that's key. Now I give the floor to Christina Laudel, will share her comments. Thank you. Greetings to all. I will, on the one hand, explain some things of COVID in Mexico, and then we will speak about the future. We need to bear in mind that in Mexico, the national health system of Mexico, the public sector is segmented and fragmented. However, in spite of having a constitutional right to health and as a human right, however, we have a weak private system with only 5% of the population having private health coverage. However, we have rapid growth in care through pharmacies or drugstores. That runs counter to the expansion of public sector in this area. And that is happening in other countries in this way. With COVID-19, the flagship was we need to save lives, and therefore care was provided to all those that sought care, regardless of their insurance condition. That's interesting because it's the first step when the public system is opened, regardless of the insurance. The IMSS was very important, the institution with the largest capacity for service provision. IMSS, the Mexican Institute, opened 300,000 new beds, and through the reconversion of hospitals, of course, for COVID, and built an outpatient care system that's called MAS. There, first you have consultation, and if possible, people were sent back to their homes with virtual monitoring. thus showing that there was important technological process along those lines. The total cost for IMP in 2021 was an increase in dollars of 1.80 billion. However, the institution was able to cover that, and the most expensive lines were salaries, medication, and healing material. Now, the negative effects, of course, was an over mortality, excessive mortality, that we interpreted that as lack of access, yes, but also because of the fear to go to the public institutions so as not to be infected. And what has been done in the last year is there is a joint work between IMSS, the health state secretariats, with the joint command. That is, it goes to the different states where there is a COVID peak and distributes patients in 3 types of hospitals: Social Security, state, and federal hospitals. And that has meant having a more balanced burden for these 3 types of institutions. And that leads towards universalization or universal services. My department raised a survey in those who have rights, and 90% agreed in that this be open for all the population, regardless of having the right to Social Security or being registered in Social Security. Also, a program is underway, a program of universalization and federalization to provide free of charge services to all the population through the well-being or welfare program. Yesterday, a decree was issued changing the situation of welfare. That is, from being a program of IMSS to be a public system. And that means that there is a major problem in the transfer of services, because with the staff, elective, federal, we have the Article 123BE, but we have collective contracts at state level. So, as I see it, at this point, we are facing a subject that is one related to what are we going to do with the rights of workers, because they are different in those 3 types of collective contracts. However, it's not clear, that is, this public organization, decentralized public organization, is not dependent from an institution. Usually, public decentralized agencies need to be sectoralized, but as it is written, there tends to be a governance of IMSS or director from IMSS, and that is something new, because the Ministry of Health is the one in Mexico that has to have, or we need to investigate how this change is going to take place. Because maybe you don't know, but the Ministry of Health in Mexico, the Undersecretariat was the one that had to do with governance, and that disappeared. So now there are many doubts as what is going to happen at national level.
We must also say that at the very beginning, a new institution was created, which was the National institute called INSABE. Now, nobody knows what will happen with INSABE. And finally, there is a promise made by the president with regards the budget. And he has stated that all the financing that is needed will be allocated to health, and we haven't yet seen that. I believe that that is a commitment which is difficult to live up to, because the economic growth of Mexico suffered severely during the pandemic, and we are only just recovering the GDP that we had prior to the pandemic. And let's see, I have 5 minutes left. And what I want to say is that we must also bear in mind that in general terms, very important social welfare programs have been implemented during this government that improves the whole set of incomes for households. And there has also been a practically 100% increase in the resilience of the public health system. However, recruitment was conducted to fill around 15,000 vacancies, and few people responded to that, few specialist doctors, because what we were seeking were specialist doctors. And faced with that situation, there are difficulties in order to strengthen services in rural areas. And so that they may have the 5 basic specializations. So that has not been achieved. And what has been done is to invite Cuba to lend a hand with those vacancies. And I suppose, and that countries know this, but that has meant that Mexican doctors are protesting because Cuban doctors are arriving, but at the same time, they don't want to fill these vacancies. And therefore, that is a difficult situation that will have to be resolved. What I can say in summary, and I think that is something that is important to bear in mind, I believe that no one can truly disagree with the recommendations of the Pan American Health Organization. However, the problem is not to produce a plan, but to implement it. That is a problem. And that is done not as from, please excuse me for saying this, not as from international entities, but nor is it done as from the desks of ministries of health. For that to be implemented, you must be out in the field and have the capability to operate out in the field so that these things can become a reality. And with that, I would like to conclude with a more political than scientific comment. We are applying something that we're applying something from bottom up, from the periphery to the center. Thank you very much. Thank you very much for a very interesting presentation of the Mexican case and for mentioning the management difficulties that often make a difference when it comes to the success of policies and perspectives. That now in the case of health, that is increasingly important given the complexity of management, both out in the field and as from the entities that provide guidelines for that. And this is an issue that we must be very aware of in order to try to ensure the success of the implementation of policies and strategies. Thank you very much. And now I'd like to offer the floor to Linshia Bahia. Welcome. Good morning, good afternoon. I'll speak in Portuñol. Please excuse me, but it's what I can do. Thank you very much for the invitation. I am very honored to be here. Even to see Asa Cristina, Vicente, Camilo. Well, for us, you're a reference point, and therefore it's very nice to be here. So thank you very much for the invitation. I have prepared a presentation that I'll share with you. Can you see it? Can you see the presentation?
Sí, se ve perfecta, se ve perfecta.
Se ve perfecta, gracias. Pero entonces...
Perfect, thank you. Maybe you can put it on full screen. Yes, of course, just a minute.
Sí, así sí, gracias.
Yes, that's better, thank you. I'm going to divide my presentation into 4 points, and the first one has to do with structural problems. Brazil faces a structural problem that is extremely important. We are the country in the region that has the worst Gini index, and this is a stable Gini index. And regardless of the policies of the dictatorship, government of Cardoso, of governments headed by the party PT, the Gini index has remained stable. It has dropped slightly, but very, very little, and therefore we face a sustainable inequality where we devastation of forests and so on. All that continues to exist, and therefore that is a problem that for those who study social policies is the worst problem. Other countries in the region have inequalities, yes, but they also experience a drop in inequalities, and at a speedier rate than what happens in Brazil. And so here we see inequalities in health. In health, we have this graph on the top left-hand corner where we see the percentage of private and public expenditure in terms of our GDP on health. What I want to highlight here is the increase of private expenditure. Public expenditure remains stable regardless of political situations, and yet private expenditure increases as from 2011. In 2011, we had we saw an increase in private expenditure. The public expenditure
pouco, pero o aumento de los gastos públicos es insuficiente.
I would like to say that the increase in public expenditure is insufficient as a percentage of the GDP. And in the graph, in the bigger graph, you can see the impact of the increase of private expenditure, especially private expenditure with private health programs. And so this is a more recent dynamic in the Brazilian health system. And we used to have a volume of expenditure similar for 75% of the population that have no health programs, similar to 25% population that do have health programs, and therefore this is an increasing inequality, and that is indeed a problem. We are involved with that structural inequality issues, and that is also present in health. We faced a phenomenon of privatization, fragmentation, very similar to what happened in other countries in the region. But we are also at present very clear on the appearance of the financial aspect, which is very important in Mexico. Recently, we published a study with involving various research on pharmacies that Ana Cristina referred to in Brazil. They are prepared to do exactly the same, to have doctors, vaccines, and we also have hospital groups that are very strong, very powerful, even in political terms, and they defend their private interests. We also have health plan companies, even international companies that are present in Brazil, schools of medicine and nursing, which is very important because we do not have an excessive number of doctors or nurses. On the contrary, we don't have a lack of nurses or doctors. On the contrary, we have a surplus, but they have all been trained in private schools. Today, in 75% of medicine schools are private, and in terms of nursing schools, more than 90% are private, and therefore there are major international and national groups that are active in that system of the professional higher education in Brazil. In terms of diagnosis companies, we have two groups that are very important, and in fact, we also have organizations that are not profit-making, philanthropic type of organizations that are also involved in that process, which is much more recent, of privatization together with these financial issues. So this is a new situation for us. And when we conducted this research, there was a context that has already changed. At this time, it is already different with the appearance of digital health companies, with the association of digital health companies and new entrepreneurial companies, and therefore we face a new situation because That is the new situation. So this a phenomenon that also becomes structural. The second point that I would like to refer to has to do with facing the how we face up to the pandemic. I believe that there is a relationship here, a list of the mistakes, missions, and the disaster of how we face the pandemic in Brazil. But I think that you already know a little bit about that problem, and therefore I will focus on what we did, researchers, scientific entities. We did react, and therefore we published a warning on the responsibility for deaths.
We were clear that the deaths could be avoided and that there is responsibility for those deaths or those fatalities, and that we have been working, raising warnings, and we have run a study for the Parliamentary Commission that took place the second semester 2021, an important study, because in that study we talk about the estimation of avoidable fatalities. So we tried to relate all these aspects, but the consequences were very, very serious in Brazil. Brazil is a country with a high number of people affected by COVID. And so that happened in June 2020. And Brazil, in that time, was the country with the highest mortality rate. But that's a phenomenon with this not homogeneous throughout the country. The Maranhão province is ruled by the center-left government, and in that province, the mortality indicators were well below the average of the country. Even the province I live in Rio de Janeiro, and the mortality there was extremely high, even with a high lethality rate as well. So there are inequalities, and political responses were really impressive, and they had impact on the overall results in terms of the pandemic. And this happened also in terms of the vaccination, which started very late in Brazil. Argentina and Chile started vaccination programs well before us. And we have national coverage, which was good, but below Argentina and Chilean levels. And here, we now, this is my third point, is, well, dialectically, what we have is that on one side, we're very happy because we have vaccinated a lot of people. The people that here vaccinations. They were bringing some carols and say that I love the vaccination system. So, I mean, we have made progress in this regard, but on the other hand, the private sector were facing risk which were very different from the public sector. They have a wider offer for little number of people, but was much broader for the ones who wanted to ask for that coverage. And this is an ad in a newspaper, which this was situation in Brazil, 1963, and women, I mean, they have to pay a price for delivery different from the other one. So that's a problem. It's a problem, a terrible social problem that we have got used to. And even during the COVID, the prices to care patients reached the double. One individual is priced one and other people are priced two. So there is a social stratification which is being incorporated into health professionals. And this point that I would like to talk about towards the end of my presentation is the future. The future is very important. We are, very close to our election for President of the Republic. We have a good expectation that we are going to change President Bolsonaro, that he won't be re-elected, but the proposal of different runners, they all mention SUS. This so favorable for SUS, and that the public funding for health will be increased, but there are some taboo topics. Candidates, they do not talk about abortion or weapons, and the prisoners also, and they do not talk about the private sector. There is no word about private sector in the programs of the different candidates. This is nothing new, but the result is that when they are elected, they do not talk about the private sector either, and the private sector is growing up. They have, the means to finally implement the rights. And so it's really incredible that during the pandemic, we do not see this mentioned in the runners programs. Runners won't talk about the pandemic because the pandemic management was a disaster in Sao Paulo, in areas with territorial population which are being involved in the 4 regions and the political alliances that have been set up. And finally, I would like to provide you with some reflection that we have to study, we have to get connected. We need support networks, and so we need to expand also our audience and the public sectors and privatize the health system in Brazil. And for that, I mean, we are facing difficult tasks. This is not an easy task, politically very complex, technically complex. So we had to work on public policies which required for support. We use the public funds to fund private health programs. And on the other hand, in that moment, we had the need to create a wide front, including all the democratic sectors, including private companies as well. And this is a task that requires to build this wide front. On the other hand, to have a group of people committed to universal policies, public policies for education, for social protection, etc. So we are now very anxious for the results of the elections and also for what is going on in Chile, Colombia, Mexico, Bolivia. But in Brazil, challenges are very specific because the private sector has grown a lot. Thank you. Thank you, Linshia, for your presentation about challenges and dynamic in Brazil, and for bringing over here the great inequality that exists there in the health sector and the challenge of how to make progress in terms of public-private cooperation and an integration, I mean, behind one single system. Now, Vicente Ortún, welcome, Vicente. You've got the floor now.
Buenas tardes, gracias.
Good afternoon. Thank you for the invitation. When I was given this title for my presentation, I found some ICLA publications such as this one, which cover the topic more than adequate, from Camilo Cid and Maria Luisa Marinho. After this, I wouldn't have anything to add, but fortunately, the organizers asked me to make a comment about the European or Spanish perspective about equity and health. And I'm not talking about equality or equity. Equity is social judgment about what are acceptable inequalities and which are not. And here it is appropriate to know what Aristoteles or Rawls say about this, especially Marcia Sen. But what it really matters is what the society think of this, because we see that equity in terms of concept, it changes, varies a lot among the different countries. I'm going to tackle on 3 points. One of the concepts of global public good things or bad things that was coined by the United Nations by the UNDP. And from here, how to mainstream equity. through health problems and not health problems. Public goods, as we know, are the ones which are available for everyone. The ones that can be used by one or the other, so cannot be divided and not cannot be excluded. When they are national, the nationalism is reinforced. This, I mean, has happened with COVID, where we have witnessed a vaccination nationalism. And when we are dealing with more than 7,000 or 70 billion inhabitants in the world, this could be global and naturally, as we have like knowledge, human reproduction, or political, such as inequality. For the very same impact in health, we can have the reduction of inequality or thematic inequality. We know that from 2 to 5 zoonotic viruses appear every year. This is a consequence of global warming. There is a loss of biodiversity, destruction of habitats, occupation of new spaces by animals. And what happens here? The global warming makes us forget about the human welfare, because we are not going to have human welfare in a sick planet. And later we begin with this revolution, the stronger will be the effort.
There are several data, but from 1 to 3 billion people, 1 to 3 billion people will be in non-inhabitable spaces. Bangladesh, where half of the population is less than 4 meters high above sea level, or India, we need to recall that the effects of greenhouse gases are cumulative, and we have a fixed carbon dioxide budget. That is, it would be 10 years emissions at present level, all of that to maintain 1.5 degrees centigrade. Now, in the last conference of the parties in Glasgow, the next one is in Egypt, several things were verified. Only that 1/5 of the global emissions with carbon price, the IMF says it's $75, and it's better to be wrong because of excess to go to 150 instead of by defect. Another figure recommendable by Bill Gates is more than the supply chains and tourism, when you have to concentrate is steel, cement, plastic, and agriculture. A public general good considers the problem of collective action. If a public good is global, the collective action would need to be of all citizens of all countries of the world. That's a lot to ask. This human being has evolved in these 200,000 years in small groups, maximum 150 to 100 persons, but you need to cooperate with aliens or foreign, or rather people, unrelated people, and that becomes difficult in to see these scenario, to see this was of the Peloponnese Wars. It has this was coined by the British author, I think, and it refers to when a country, when a city, like in the case of Peloponnese and Athens, saw that Sparta could displace it from the hegemonic role, declared a preventive war. And after 30 years, both Athens and Sparta were devastated. And then let us put Instead of Athens, US, and let us put instead of Sparta, China. Difficult to get cooperation. One should expect world cooperation for warming, global warming. So we need to think of broad coalitions of compliers, not to have voluntary support and support of international agencies, World Trade Organization, for tariffs that are imposed on non-compliers be executed. And thus, the market solutions is one, but a decided action of the state. But in the Stone Age did not end because the world was left without stones. No, that means that between 65 and 80% of oil and gas reserves need to be buried. Rather, if we don't want to exceed the 2 degrees centigrade target, the state solution has this sustained effort for renewable energies to replace the fuel ones, fossil fuels, and not supplementary, and to avoid problems like that of people's reaction against, like the green jackets of yellow jackets of France. You need to think about distributive taxes, like taxes on carbon. Each one will pay in terms of what you emit. But after, as a citizen that are owners of the legacy, will receive or will similar amounts, adjusted amounts. It's a way of not having a radical opposition to having taxes on carbon. Another good or another public good or evil that affects health is inequality. Only between the end of the World War and the 80s, the world lived a period of attenuated inequality. Milanovic and Piketty have explained that. Another way of reducing inequalities through epidemics, wars like the First and Second World War, revolutions like Russian or Chinese, or failed states, but it's not an advisable mechanism. Inequality, we know that intra-country has increased, world inequality has declined thanks to China and India. And the increase of inequality in 1980s has been accelerated by COVID, plus the democracy and growth threats. But on economic growth and democracy, usually we are used to measure inequalities in a static manner with Gini's a high frequency one is calculated by the social provisions of services. If each month a sample of banks or persons of a country give you the list or payrolls or social provisions can be matched with a Gini's. Also, this can be considered compared to epidemics. And if you calculate and you had to have this instantaneous Gini's. More than static data, I like the dynamic data. You can be poor or be at risk of exclusion, but it cannot be that your children be doomed to be poor or at risk of exclusion. So inequality in dynamic terms, when in a society the position of a child is explained by the position of the parent, there's no mobility. When you inherit wealth, education, and context, they have no vertical mobility like the US, of course, or UK. This is a way of calculating vertical mobility, what is called the social elevator or social lift, that collects, it's calculated like 1 minus correlation between years of schooling of children and parents. What do we see is that normally there is a high correlation among countries that have low Gini index with countries that have a high vertical mobility. Those of high vertical are the Scandinavian countries, Finland, Denmark, and equity. There is progress in knowledge. We know the persisting effects of adverse child circumstances, particularly uterine conditions and the first years of life. We have massive data. The last work of Chetty, which is of August, is great, working with data of the population universe. Credibility of empiric social science analysis has increased and you need to be mindful in these progress that in social sciences, that knowledge needs to be applied as a medication, as in medicine. Like Roderick said, that without knowing, that paraphrased William Osler, one of the fathers of Johns Hopkins, it's more important than establishing the diagnosis of a patient is to know what patient has a diagnosis. In non-health policies, remembering that wealth creates power and power creates wealth, in many countries, it's better to know, to have context instead of knowledge, and saying that fiscal competition among countries hampers the introduction of progressiveness as well as the creation of a global register of financial assets, an antidote to capital laundering and fiscal or tax evasion. We need to say that health, publicly financed, and especially education, to the extent that they create human capital, this promotes pre-distribution of wealth and income. Secondarily, health, especially primary health care in Spain, is distributive. It's indispensable in those countries with education and health to extend the available income calculation, and Gini usually improves in those cases. Non-health policies, well, the most outstanding is education. If we want to have equal opportunities, you need to focus in preschool and primary education, because what happens in the first 5 years of life will affect the conditions of future life as well as the health of the person. And education is not only the one that accounts mostly for the health status of an individual, but rather it's the one that allows you to increase productivity, social conditions. With a better education, it's correlated not only with having higher salaries, better health, better trust, better political activity, better participation. And even those who had AIDS or had a high education, the possibility for them to infect was 1/10 of those who had less education. And now to finish, in health, everything has been said in health policies. Public health, there is a bill that has been approved to have a state agency, and this will depend on the starting point of each country, but underscore what has been said so far: primary health care. It's the only component of health care where a greater supply is linked to a better health in the population and with equitable results. Therefore, primary health care is a common good whose robustness and quality constitutes a collective concern. Now, not countries with little public financing, but also in rich countries, we need to think. For example, in the epidemic, hospitals, many spoke of the thousands of cases cared by hospitals, but the millions of cases to have a working operational primary care, it involves also to know in what society you're in. If it's non-health, education that not only affects health, but productivity. And in health, public health and primary health care. Those are the elements, those are the take-home messages, and that's my email if you want to ask for one of the articles I've quoted. Thank you very much.
This presentation reminds us of the debate between equality and inequality. It also deals with the dynamic of climate change and its effect on health, and that is a very strong future issue, and also the idea of how to assess health actions from a new perspective on equality. And that, I believe, is very important. And for our next presenter, Camilo Cid, that issue certainly forms part of his concerns. So without further ado, I'll offer him the floor. Thank you. Thank you, Daniel. First of all, I'd like to greet the panel, all colleagues and friends that are present. I would also like to thank the invitation of the organizers and the previous presentations that have all been very important. As from the viewpoint of financing of the economics of health, so to speak, and also as from a national perspective, from the Chilean perspective, I would like to refer to 5 points. I'd like to talk a little bit commenting what has been said with regards to the challenges faced by health systems, and especially the Chilean health system. To characterize that and subsequently describe the new challenges that have emerged over the past 2 years as a result of the pandemic, so that we can subsequently talk about the public policy response to tackle problems, both past problems and the problems that have accumulated over the years. So I'd like to first of all refer to challenges. I don't have a presentation as such. In any case, I can send one of the ones that we have been working on as FONASA. But basically, this refers to advancing towards a health system with coverage and universal access, with quality services for all people. This is not an easy task. It implies overcoming important barriers in our countries, and one of the most important one is the financial barrier, but also others, and those related to supply issues, to the fundamental supply elements in a health system, such as human resources, capital, and technology. The buildings, the beds, the health devices, together with technology and medicines. Now, part of these objectives of increasing capacity levels, we also need to consider the classic health problems faced in Latin America, but also in Chile. We talk of segmented, fragmented, and chronically sub-financed health systems as from the public system. In Chile, this is lesser in other countries, for example, lesser in Mexico. In Mexico, there are several segments of the system or several subsystems as a result of the existing social security organizations that exist. And they also have a federal system. But here in Chile, we have two subsegments, the private and the public segments. But the degree of difference is far deeper compared to the other countries that I have mentioned. And this can be reflected in per capita expenditure, which in the case of Chile in the private sector easily reaches 3 times what is spent by a person, considering what a person in the private sector spends, considering what is spent by a person in the public sector, and that creates tremendous inequality issues and also has an impact on the results of health. And therefore, we have populations with differentiated results, practically 2 countries living in one single country. One could say that practically one part of the country that has health results and expenditure similar to European countries, similar to Spain in the case of the Chilean private system, with another world, the world of the public sector that has expenditure levels which are closer to our neighbors, such as Peru, for example. And the fragmentation, therefore, is another important element that determines organizational aspects of services, the overlapping of functions that are also exacerbated as a result of segmentation, different and practically stagnated systems, the private and public services that don't talk to each other, and public services that are also disorganized. If one wants to pose this problem in financial terms, so this is expressed in Chile in the high expenditure on the part of beneficiaries and the low level of public expenditure. We are not at the level of the GDP in terms of these indicators. In terms of GDP, we're very high in Latin America, but in terms of public expenditure and health, we're at a mean level in Latin America with very complex problems, and we are falling behind many other countries in our region, and this has a consequence on expenses that are catastrophic and that impoverish people, and also have to do with the sustainable development goals. Well, we face difficulties in the case of these indicators. We have 14% of our population with catastrophic expenses, and with a high percentage of people incurring into expenditure that impoverishes them. And this has to do with the organization of the health system, where there is little financial coverage in the private world. In the case of ISAPRES, which is expressed in this 14% of people who spend an important part of their budget on health. But there is also a segment of the population that demands medicines and that used to make contributory payments in the health sector that could fall into poverty as a result of that. And I say that with those words because I have just arrived from an activity that today we launch the elimination of co-payment in the Chilean public system. As of the 1st of September in Chile, the public sector is completely free and free of charge. And therefore, we hope to be contributing to that segment, to that 2% of the population that becomes impoverished as a result of health expenses. Now, this description and this characterization of Chilean health problems are aggravated as a result of the pandemic, as occurs in many other countries. We faced an accumulated demand here in Chile. Today, we face a 2- or 3-fold increase in demand as a result of the fact that people did not, during the pandemic, did not go to health centers, and the system as a whole had to be devoted, practically the whole supply of these health centers, of the whole system, including the private system, was devoted to catering for COVID-19. And therefore, that demand was accumulated and is becoming apparent today. And therefore, we face waiting lists that were non-existent in the past. I imagine that in all countries in Latin America, they existed, but the data that we have here in Chile Chile, these waiting lists have increased threefold. In terms of outpatient issues, specializations, or surgeries. And they place an excessive demand upon the health system, and therefore dealing with that implies an additional problem. And I would like to say that we have been able to respond, and a first response is the response to the pandemic. And there is something characteristic of Chile, which is the vaccination process. The vaccination process has been very successful, upheld by a solid primary health system with problems, with challenges, but very solid and capable of reaching all parts of our territories and of organizing a national immunization program that is highly consolidated. And in that sense, vaccination in Chile has been a great success, the only country in the region that has a booster shots that have been so wide-ranging, and that has mitigated the effects of the pandemic. However, we have to say that when it comes to measurable effects in terms of excessive mortality, that doesn't mean that we're in a situation where we should be. That extra mortality before vaccination was extremely high, and it also puts us in a medium range in our region, and not within a range similar to more advanced countries with more advanced health systems. The immediate response, and by now one can already begin to refer to the post-pandemic, despite the fact that it's not completely over, at least not in this country. However, the response has also required a different vision, and this coincides with a different political vision, with a different government, we have to say that. And that comes with a reform proposal, and I would like to conclude with this point: the reform proposal that overcomes both problems. It overcomes pandemic problems and also problems that were already in existence in the health system. Is a proposal that implies a structural reform. The reform basically implies moving to a universal health fund that accumulates all the financing that is available for health in one single institution. And we are saying that the Universal Health Fund in Chile will become an institution that actually finances the health system, and therefore we're talking of a fund that will collect resources, bring them together in a solidarity manner, in the best manner possible, and distribute them among providers in terms of or based on efficiency and based on expenditure, and also with components that refer to the prioritization of services and the definition of the contents of the benefits that people will receive, in this case, in the Chilean health case. The other part of the fund is the financial part, and therefore this fund is called upon to provide financing the universal health system. It has a service component, care services, which is called the National Health Service. The denomination is not casual, because the message that conveys is that we want to advance towards a national health system, a hierarchical national health service based on primary care, universal primary care, improved with capable to resolve problems and to articulate the upper levels of the network. We're talking here basically of the development of integrated health networks based on primary health care strategies. These two components are the most important ones, but obviously there are others, such as the prioritization processes. We want to create an agency to for health assessments, and in this transition we envisage, of course, the participation of private providers within the universal health system with public rules. That is how we have expressed this. In other words, with the same demands in terms of quality, financing, in terms of capacity, than that the public sector, and that will be applicable to the private sector. The reform also envisages supplementary insurance, second floor insurance, as we call it, but outside social security. And in that sense, this is a voluntary assurance that people can gain access to in order to obtain more comfort in the services that are received normally. These are the main elements, and with this, what we want is to increase in a very relevant extent access to services, the quality of those services, and of course, I believe considering a financing component. In Latin America and in Chile specifically, as I mentioned at the beginning, where we have a low budget, we have never gone beyond 5% of our GDP, but we want to advance towards the average recommended by PAHO, which is 6%, and even go beyond that percentage and approaching OECD countries that through an implementation plan can generate capacities as from supply, and thus truly scale up the resources capable of absorbing the health demand. Everything that I have commented, of course, has a political aspect. It requires laws in parliament. It requires a wide-ranging consensus on the part of different groups. They need to be convinced so that this can become a state policy, and major groups of the population and political groups have to approve this so that we can approve the set of laws that this implies. Thank you, Daniel.
Thank you, Camilo, for putting forward these topics, such as a key issue that is equity in Latin America. And when we compare this region with other regions, this is a very strong barrier, and this explains the catastrophic expenditures that we can observe in many countries in the region. And so to put on the table some other aspect, the structural reforms that I imagine that this is a very important dynamic you are discussing. We are about closing this session. We cannot extend so much, so I will give you a couple of minutes to the panel members if you want to add something or discuss about what you have heard during the presentations today in terms of how to measure political aspects and equity. 2 minutes each, please, in the same order. And we want to respect the time of interpreters. Okay, I would like to say just that I think that we have a lot of things to do all together, supporting the countries. And just to remind you that in this moment, we are going through a critical moment. So we need to take advantage of these circumstances and to accompany the countries which are now getting on the board in the transformation process, which are more sustainable. Thank you, Daniel. Thank you, Alberto, and dear colleagues, Maria Luisa, Camilo. And thank you to all the community for this opportunity. Thank you, James. Christina? I would like to insist in two aspects. I think that the most important thing is what we see, that progressist countries are putting forward all changes. So we are going to need the political will to do implement all these changes, because there are many interests. That's why we require the political will and political support as well to go ahead with these changes. But simultaneously, I would like to insist on what I said before. That could be something obvious, but it's very different to manage policies which have been adopted than to implement them. And so where we don't need only data, but the conditions to implement those changes. Thank you so much for inviting me to this panel. I think that has been very fruitful and interesting. And I also wish you, the ones who are entering new processes and new elections, I wish you a great success. Thank you and goodbye. Ligia, I would like to thank you all. I'm very happy for being here. And I think that it's very important that we adopt deprivatization indicators for our countries, because this is not simple to increase public expenditures and simultaneously increase private expenditures, and we could reach a situation similar to the ones in the United States, where we have simultaneous increases and the GDP in health grows, but not necessarily needs to go towards a universal public developed health system. Thank you. Vicente, thank you for the invitation. And I repeat something that is obvious: a public funding is a unique system that should be efficient and equitable. If we do what we are going to pay instead of repaying democracies are going to be, the money wasted. So it's difficult to expand public expenditure in unequal countries. We shouldn't forget that the redistributed policies and education is more powerful than health. And the last thing is, without good governance, it's difficult to expand public funding. Good luck. Thank you, Camilo. Yes, probably to warn you about the perspective of the other countries. I mean, the consequences of the pandemic in terms of household funding. And I mean that after some progress increasing, the pocket expenditure for quite a long in Latin America, it's very likely that when we forget about this data and pandemic, we are going to find an increase on public household. I think that this may happen in an unequal manner, because the pandemic has affected much more the lower income sectors, so they are having pressure on this direct expenditure on households. So probably we are accentuating this, worsening this poverty and inequality circle. So I want to set up a warning about this, that we need to find a balance. We need to discuss about the fiscal spaces to create mechanisms to compensate to can solve this problem, that the countries should look for the political ways to provide solutions to these problems. Well, thank you so much. I just would like to thank the panelists for the excellent debate, highlighting key aspects where we're thinking of how to strengthen towards universal, equitable, sustainable coverage of our health system. And so I thank you all. I don't know if you, Alberto, would like to add something or we close the session right now. No, just thank you, Daniel. Thank you for being the moderator. Thank you, James, for support of PAHO to this regional seminar on social development. Thank you, Vicente, for your time. Thank you, Ligia. Your Portugal was great. And Vicente, we will keep in touch and with all the things that has been discussed. Thank you so much. A lot of what has been discussed here, and many of us have been in different circumstances discussing the same, and we want to go ahead with the project that has been implemented also at MinSal. So thank you so much. Had been more than 200 people online, and after 3 p.m. Chilean time, we will continue with seminar and with panel number 5. And then we are going to, we will continue discussing with health system. We are going to have a very interesting panel. Thank you, everyone. And we will keep in touch. Bye.
Hasta luego, muchas gracias.
Chao, gracias.
Don Simone ya está avisado con respecto al streaming, así que podríamos empezar justo a las 3 como a la hora que usted indica.
Sí, perfecto. Empezamos a la hora, ¿no? A
Sí,
las 3,
Simone,
¿sí?
al parecer de la señora de la calle,
¿Sí?
vamos a tener ahí un reemplazo de la doctora Calle, nos están comentando en este minuto, así que te voy a comentar, ¿ya?
Ah, perfecto. Me mandas
Un
los
mensaje.
datos. Sí, sí. Súper.
Muchas gracias.
Mm.
Muy buenas tardes.
Buenas
Good
tardes.
afternoon.
¿Cómo les va?
Muy bien, encantado, Miguel.
Lo mismo digo.
Hola,
Miguel, ¿cómo te va? Tanto tiempo.
Ernesto Váscolo, ¿cómo anda? Placer de saludarlo.
Qué lindo verte.
Lo mismo digo.
Por la pantalla te paso un abrazo.
Lo mismo digo. ¿La familia bien?
Todo bien, todo bien. ¿Y allá cómo andan?
Bien, bien, acá estamos manejando las complejidades de la pospandemia.
Sí, sí, lo sé. Bueno, un gran placer compartir con vos, Miguel.
Lo mismo digo. Vamos a ver si podemos a volver a hablar de vinos viejos en toneles nuevos.
Dale.
Que ahora son resilientes.
Lo importante es que el vino esté bueno.
Eso es lo definitorio. Muy bien, está Claudia Robles por ahí también.
Sí, sí, está Claudia.
Sí, que
Y
acá
vamos
estamos coordinando.
Hola, ¿cómo te va?
Un
Lo
gusto
mismo digo.
realmente conocerlo en persona. Y bueno, a Ernesto, a todos y todas, gracias.
En un par de minutos ya vamos a salir al aire, ¿ok? Así que
muy bien.
Ahí esperamos la hora, así partir, ¿verdad, Claudia? Partimos a las 3:00, ¿sí? Perfecto.
Sí, por favor. En atención al equipo de intérpretes también, porque ellos no se pueden quedar más tarde. Entonces, después tenemos la sesión de cierre. Gracias, Simone. Mi colega.
Muy buenas tardes. Estamos ya.
Good afternoon. We are just beginning.
Perfecto. Entonces, muy buenas tardes a todas y todos.
Good afternoon, everyone. I'm Simone Cecchini, Director of CELADE, Population Division of ICLAC, and for me, it's a real pleasure and an honor to start and moderate this panel of the second regional seminar on social development of ICLAC. And in this panel, we're going to focus on the need to strengthening social protection systems of countries of Latin America and the Caribbean, and the main challenges related to restructuring of health systems. We're going to talk about inequalities, how they persist in the health sector, and the great impact of social determinants of health. which is an evidence of the urgency to articulate the different health systems and social protection system. We are going to focus on the main dimensions that requires to be taken into account for the reform processes of the same health systems to contribute to what all want, that is transformative recovery with equality, with an inclusive social and development and sustainable at the same time. You know that Latin America and the Caribbean has been one of the most affected regions in the world because of the pandemic, considering the death because of COVID-19 in a number of 27.2% in the world and the 8.4% in the global population. And this poor record is connected to different risk factors, such as the fact that 81% of the population is living in cities, and very frequently the people they don't have access to water, sanitation, electricity, they live in crowded places, which cooperated for a quick spread of the contagious. And of course, to take in taking these results, this is connected to the multiple inequalities which are reinforced among themselves, such as gender, socioeconomic level, race, gender, territory. And that has made that individuals which were more vulnerable prior to the pandemic, they have been even more affected because of COVID-19. And the poor results are also connected to the structural weaknesses of our health systems. And in this panel, we're going to deal with this topic: the universal access to health coverage, universal coverage, necessary aspects for access to health by all population. These objectives are shared by all, but it's important to talk about how this indebtedness of fiscal contribution will have impact on all these crises are moments of opportunities at the same time to cooperate, to lay down the foundations for a better future. And that shows the history of one of the agencies represented here, the PAHO, which was founded in 1902 as as a kind of response of the consequences of the yellow fever pandemic that we had in the continent. So we hope that now we are going to be strengthened also after this pandemic with more robust health system throughout the region. We have a great panel to discuss these topics, and we will begin with the main presentation, about 20 minutes, which is going to be rendered by Maria Luisa Mariño, Social Affairs Official of the Social Development Division at ECLAC. Maria Luisa, or Malu, as we call her, is a technical focal point, and she is in charge of the health area, and she works on social protection issues and labor inclusion. She is a sociologist by profession, master in social policy London School of Economics in London, PhD in social policies of Wolver University. Without further ado, Maria Luisa, you are recognized. Thank you, Simone. Thank you for your introduction. Good afternoon, everyone, and the ones who are online and virtually connected to this panel. Special greetings to each one of you, as well as Alberta Agustine who will be with us. Greetings to Miguel, Ernesto, Alberto, Álvaro, Ramon, who have already connected to the session, and I'm going to share the screen now. Well, my presentation will focus on, this is a joint work that we are carrying out with Alberto Arenas, the Director of Social Development Division, and Antonia Daguada, which is part also of the members of the division, and some elements of a paper that we have published with Camilo Cid about the 2 years of pandemic of COVID-19 in Latin America and the Caribbean as part of the project Transformative Projection, Transforming the Situation in Latin America and the Caribbean, and carried out at ECLA together with the NBZ and GIZ, and some work carried out by Mauricio Matos, who made an analysis of the pandemic as an opportunity for change in terms of vulnerability, social protection systems in Latin America, and the development also of the European Union in line with this. So a couple of messages that I would like to provide you. Now, the first one is a message that will be present throughout the presentation, that health is essential for a sustainable development. Without health, we cannot think of an inclusive social development or an economic and sustainable development. And this has been made more than clear by the pandemic. Prior pandemic, the region had made some progresses in terms of population's health, but those progresses has been imprinted by deep inequalities, as we will see in this presentation, inequalities which relate to the structural aspects of the matrix, as well as very closely related to structural weaknesses of the health systems and social protection system and social determinants. All these are correlated, and this is common to the countries in the region and to each country individually. As Simone said in the introduction, the region has been highly vulnerable during the pandemic, with the highest levels of mortality rates, contagious, etc. And this has been linked to a health, social, economic crisis, which was prompted by the pandemic. And we see the social crisis is still active and with impact that are still unforeseen. The right to health has been threatened by the health crisis, as well as by the great impact on the social determinant for health, and which provides us with this window of opportunity to make progress in health systems, making them comprehensive, universal, sustainable, and resilient, guaranteeing the right to health, and also considering the current context of the region and globally, where risk structures have been renewed, and now we're going through a climate crisis, which has been present for quite a long time by now. To make progress towards these health systems need to go in hand with social protection systems, because that's the way how we can make progress to approach the social determinants for health and to overcome inequalities. So now we're going to talk about health as a central element for sustainable, inclusive social development. In this slide, I'm showing you the different dimensions where health is related to sustainable development. And this is related also to the social inclusive development, as well as the economic development, environmental sustainability. And in each area, there is an impact on health and vice versa. The pandemic has surfaced very clearly that without health being guaranteed to the population, people cannot have access to work, and they cannot study, they cannot take care about others, and a great impact in the end on the different dimensions of sustainable development, and also affecting the levels of equality, living conditions, working conditions, which also contribute to the different health status. When we consider that these three dimensions of sustainable development are linked in a systemic relation, that they are interdependent, we see that it is truly necessary to have comprehensive policies putting the health at the core of the systems to make progress towards sustainable development and to guarantee the right to health. Public investment makes a contribution not only to health, but strengthening the health systems and the population's health, together with other dimensions which are essential for a sustainable development. A high investment in health will also contribute to have better results in terms of inclusion, reaching high levels of productivity, highest economic growth, and reducing poverty and inequality. So in this regard, one of the messages that we want to convey here is that investment in health is a requirement to make progress towards an inclusive social development and also to face sustainable development within equality. The impact of health on sustainable development has been made evident through the backwardness in terms of the 2030 agenda due to the pandemic. And according to ICLAC information, almost 70% of the goals set by ICLAC by 2022 won't be reached by 2030. And this is because of the pandemic and the different crises because of the same. 22% of the goals, which are in red color, I mean, the yellow are making progress very slowly, but the ones in red has gone backward. This was very clear in the case of poverty, SDG 2 to put an end to hunger, welfare, and about the targets related to employment, inequality, etc. So there are different dimensions where we're not only to making a slow progress, but we are, advancing in the opposite direction. How this will evolve over the next 8 years, well, here what we are presenting is the need to have policies meeting the SDGs, putting health at the center. It's important to consider health in every policy that we are going to be dealing with. Prior pandemic, we see that the health in the region was affected by inequality in the different regions, despite progresses that we have seen over the last decades. But what we can see in this chart is the result of an analysis in terms of the evolution of the key indicators, such as life expectancy, child mortality, and also maternal mortality. So in this slide, I'm showing the case of maternal mortality over the last 17 years. The rate decreased in 23.2%, the regional average 73 deaths per 1,100 born. And so 13 countries in the region are over this regional average with, causing great gaps. If we consider all the Caribbean, the maternal mortality rate in Guyana is 6.8 times higher than Grenada. And that type of inequalities remains in different countries in the region, and they are repeated when we consider the maternal mortality rate or the indicator of mortality or maternal mortality. And we can observe the different social determinants together with this analysis, and we see the life expectancy of countries of Latin America with the highest levels of poverty. They reduce and is lower in those countries with higher levels of poverty, and this relates not only with problems in terms of access, coverage, of quality of the health systems in those countries, but it's also related to the social determinants for health throughout the life cycle in different areas. As in the former panel was mentioned by Vicente, the conditions, the life conditions, economic and social conditions of individuals, which are putting conditions also on the development of their own lives and the health status. The same is in terms of social determinants and is expressed in lower levels of life expectancy.
en otros indicadores.
This is also seen in other indicators, other health determinants like levels of schooling, labor informality. Likewise, we see the gaps to be according to structuring access of the social inequality matrix when considering quintiles of income, territories, they live in rural or urban areas. If people belong to indigenous peoples, Afro-descending peoples, all of these pillars or axes mark different results in terms of health. And the likelihood of dying before 5 years of age is higher among those that belong to the lowest income quintile. The graph shows differences among countries, but we want to emphasize differences inside one same country. These gaps unfair limit the capacity and opportunities of persons for their development. This gradient is also repeated in other clear indicators like maternal and neonatal mortality. In view of this context, prior to the pandemic, what I was showing you was previous or prior to the pandemic. The right to health has been jeopardized due to the crisis triggered by the pandemic. And here to refer to some of the work that we have conducted in these last 2 years, addressing health and inequality. This is a chapter of the social view of Latin America of last year, where we see the pandemic, inequality, and the work with Camilo Cid on the 2 years of pandemic in Latin America and the Caribbean. Some of the messages that we presented in those reports is that inequality, which is a characteristic of the region, is cause and effect of the unequal risk for COVID-19. As mentioned in this morning's panel, the risk of contagion or developing a severe disease or dying because of COVID-19 has not been homogeneously distributed in the region, but rather mainly concentrated in vulnerable populations. Also, this population had greater health deterioration, and because of the social inequality. And what the diagram shows is that there is a vicious cycle, higher levels of inequality, higher probabilities of having severe diseases, and all this related to chronic underfinancing and segmentation of health systems, and also undermining social protection. This combination of factors generates a situation where inequality is deepened in view of COVID-19, and this not only can be observed inside a country, but also is part of the explanation of the higher vulnerability of this region as compared to other regions in the world. And here we have mentioned the main effects of the pandemic on social determinants of health. There is downgrading of these elements, and that lead to an increase in inequality in health, an increase in poverty, in extreme poverty, higher levels of informality, unequal labor participation, especially for women, with effects on education and inequality. This is not homogeneously distributed, but it's marked by the structuring axis of the social inequality matrix, and therefore produces and reproduces inequality in health. This is inequality has also been observed in immunization processes in the region. And mid-August of 2022, of the 33 countries, still they have not reached out to 70% with the 2 doses. However, there are countries with reinforcement booster doses and even 4th doses in some countries. Impact of the pandemic has been unequal when considering the excess mortality. The excess mortality is an indicator that covers not only deaths confirmed by COVID, but also deaths that were poorly or incorrectly registered or recorded, as well as all the deaths generated by the health crisis and by the interruption of essential health services presented by James this morning. We see that countries with a higher levels of informality had higher levels of excess mortality. And this is also observed when considering the poverty and extreme poverty levels of countries. And therefore, there is a need to move forward towards universal health systems, well articulated with social protection systems, and at the same time ensuring that people will have access to medical needs regardless if there is a crisis or not in the country. And then to conclude, after having seen the situation prior to pandemic, how inequality was exacerbated during these 2.5 years of pandemic, well, there is this historical window of opportunity to conduct the transformations that the region requires in order to guarantee the right to health. And thus, the goal of CEPAL, of ECLAC, is to consolidate universal health systems that it should be comprehensive, sustainable, and resilient, so that may face inequalities in health and allow to advance towards sustainable development. Health is key for every social development inclusive strategy, and therefore for any successful strategy of sustainable development. It's clear that there will be no sustainable development if the right to health is not guaranteed on equal basis to the population. It's urgent to implement transformations to the health systems where coverage is ensured, and it will depend on the needs of the population, not on payment capacity, that they be integral capacity to cover different demands articulated with other sectors, that they be sustainable. Coverage and quality should have financial sufficiency, and also that they be resilient, that they may face crisis without without interrupting health systems. And here I would like to mention the need of strengthening the articulation between the system of health and social protection, and therefore the strengthening of primary health care is key, because through that level of care, you can have this coordination and address the social determinants of health. What we show in the diagram, these are some tools of social protection, and that can have a positive impact on social determinants of health, therefore contribute to better health levels, and at the same time, if the health level is better, to invest in health will have better results in other social dimensions, like reduction of poverty, less inequalities, and that will also contribute to the quality of social protection. And in view of the historical opportunity of transforming health systems, that is, at this point, after 2.5 years of pandemic, there is social consensus on the need to move forward in health systems with these characteristics, and that will allow to face the inequalities in health. We need to leverage this consensus and moment and conduct the informations and reforms that are necessary. And thus, we need to consider the different dimensions related to the reform. We need to have a technical debate on which ones are the best models, the best one to be implemented. Political debates considering political and economic interests involved in a reform of this type. It's necessary to conduct cost analysis, ensuring financial sustainability for the reform. Also, considering institutions and how this dimension conditions the type of reform to be implemented, and strengthen the communicational dimension, contributing to the development of a public narrative that will consolidate this present consensus on the need for reform. And now, to conclude and to progress in this, in allowing right to health and overcome inequalities in health, we need a new social fiscal pact. Thus, it's essential to consolidate a new social pact centered in the rights of the population, with equality at the center, and linked to a progressive fiscal pact that will guarantee financial sustainability of the, and thus all the investment required for the reforms in the health system to overcome the chronic lack of financing. There needs to be financial sustainability that will help to strengthen social protection systems, because health is part of social protection, social security. And thus, it's key, fundamental, that this financing model it's going to be developed for reforms to be based on solidarity, overcoming present segmentations, and thus doing away with inequalities, ensuring thus that access to health be a right determined according to the need of the population and not according to the payment capacities. And thus, we reinforce the message of structural reforms that will advance in guaranteeing the right to health as a mechanism for facing inequality and building sustainable development with equality in the region. Thank you very much. Thank you, Malu, for your excellent presentation. You gave us a great initial overview of the centrality of health in sustainable development. Still, we are far from reaching certain targets or objectives, but it's possible. Well, however, inequalities are major, strong, and the data you showed between life expectancy, poverty, excess of COVID mortality, informality, and all those links, all of that shows how fundamental are social health determinants. We knew it, but with the pandemic, we had case studies that transparently showed how important it is to take into account social determinants of health for our public policies. And of course, you provided us with many conceptual elements on where we need to head to and transform our health systems. You clarified what is integrality, resilience, universality, and the link with social protection, what we call, which is different sensitives universalism or universality. And then finally, the reforms, the mission, and the social fiscal pact, which is difficult to achieve in such unequal societies, but hopefully, in view of the importance of health that has been evidenced by the pandemic, it's very important. Now we'll continue with a series of shorter interventions, 10 minutes each. We have really an outstanding panel: Miguel Fernandez, Ernesto Váscolo, Claudia Robles, Miguel Gragnolati. We'll begin with Álvaro Ramos, Executive President of the Costa Rican Social Security Institution. He's graduated in administrative IT and in economy from Costa Rica University, and also PhD in economy in Berkeley University, California. It's a pleasure and honor to have you here with us, Álvaro. You have the screen.
Thank you very much for this possibility to share with you the experience in Costa Rica. I understand that we have shared the presentation. Maybe somebody should show it. I also have it, but maybe it's easier if you show it on the screen. Otherwise, I'll do it.
Estamos coordinando acá. Don Jorge, ¿tiene ahí la presentación?
Gracias, muy amable.
Sí, creo que lo tengo acá. Deme un segundo.
Perdón, ¿lo hago yo o lo hacen ustedes? Me perdí.
Estamos ahora por proyectarla. Muchas gracias.
We'll share the screen from our side. Thank you. Okay, continuing with the presentation and with the ideas that Maria Luisa has just presented. Let's see, next slide. We are very proud with our social security system, which basically relies on the Costa Rican Social Security Fund. When I talk of the first world, the provision of health is perfect. We're not saying that our system is perfect. We have many, many imperfections and many challenges. But in conceptual terms, we want to be a first world institution in the health sector. And we also provide economic protection for the elderly, for disability, for orphans. We provide protection in all these scenarios for the beneficiaries of the fund. And historically, we have always had relatively low costs. When I have investigated costs that have lower costs, but normally they have a different social configuration to ours. For us, it is extremely expensive to cater for teenagers that have accidents on motorbikes and so on. When they have, where they have lower costs is where they have better public transport, where people normally use public transport or walk. So we have situations in Costa Rica where public transport is very good, and if the public transport is not very good, people use motorbikes, and that adds or contributes to higher costs. As I said, that concept of a first world institution that we have focuses on primary care. We also have specialists that deal with their specific aspects, but what has is very good is our primary specialized primary care. Our social security coverage for 4 decades now is greater than encompasses more than 80% of the population. And we soon expect to reach a level of 90%. And we're still aiming towards universality because we already have this high coverage. It is comparatively cheap to reach universality. And in addition to that, to the fact that it is less costly, much of this coverage is stipulated in our laws. So people that suffer certain disorders, they receive this coverage even if they're not insured. So it's we provide coverage to most people, and therefore we don't have to resort to the law. some people are rejected because they don't have coverage for primary health care, but at the end of the day, we will still have to cater for them. If someone suffers from high blood pressure or diabetes, if we don't control them, this will end up by being far more costly. But where we have a wide-ranging structure with the capability of providing coverage to this whole population, we're able to somehow face up to this issue. We also face a tremendous challenge in the sense that we are an aging population, and that aging is far quicker than in developed countries. And we are in quite a mature stage of this aging. We have moved from the pyramid that we had in the 60s, but from this pyramid shape, we are a population that is becoming older and older. And by 2015, we will have the shape that you can see there on the graph. But in addition to having this population dynamics, we are a country with tremendous economic difficulties. In fact, in accordance with the OECD, we're the most unequal country in the OECD, only behind Mexico and Chile. But that confuses Costa Ricans because we ourselves have an image that we're a very equal country. But ironically enough, that perception of equality has to do with, to a large extent, with the access to health services. People say, well, I don't have too many resources, but I have access to a first world health system. And that historically, we believe, has meant that we perceive ourselves as a more developed society than we are, than we in fact are. Now, despite the fact that we have a commitment of providing services to more than 90% of the population, from the viewpoint of contribution coverage of the working population, we still have a long way to go. With salaried and non-salaried workers, we reach a total of around 2/3 of the people. So we still need to cover 1/3 of the working population. And because our working population is relatively small in any case, and therefore from that viewpoint, this direct contributors only represent 1/3 of the population, and therefore we have a challenge there in the sense that we need to cover practically all the working population to achieve those additional resources or seek new financing mechanisms. So the main areas of action, and this wasn't mentioned by Maria Luisa, but we are especially concerned with containing costs and with improving care. And one of the recent concerns that we have is that the Ministry of Health and our fund has been geared towards the prevention area and to attack early on the health needs of the population. And that, but that has changed recently to focus more on curative action, but we want to focus on prevention. And under that logic, in the short term, we have in our investment portfolio, at least in terms of primary care, 33 different health areas and 24 EBAIs just for this year. 24 EBAIs for this year, and for future years, 3 or 4 or 5 years time, up to 340 new EBAIs. And those that don't know this acronym, EBAIs, is the basic primary health care unit, and that is very important because it is the first line of defense, so to speak, for health in Costa Rica. We have estimated that we have 1,000 we should have around 1,400 to provide primary health care with the same quality that we have at present. And even so, we believe that we have to strengthen this even more and enhance capacities in the sense that today the person goes to this primary healthcare center and they can resolve certain health issues, but perhaps we could resolve many more aspects. We could provide more medicines, we could have or provide more medical procedures and resolve many other issues, because we have many we could perhaps have more specialists such as family doctors or community doctors and have general physicians through training and through the reconfiguration of our internal organization with our different protocols. And if we improve this, we feel that the population could feel that more health issues are resolved during their first visit to these primary healthcare units, instead of moving on to the other levels of the healthcare system, which ends up by being much more expensive. And therefore, the main promise for us is, first of all, universality. We are not too far from that, so we feel that we can achieve that. Secondly, transparency. We have a problem. Our financing scheme relies on 35% of the population, which is a population that is in formal employment, and therefore we must find a wider financing mechanism, perhaps as a result of general taxation and so on. And based on that, perhaps we could achieve greater sustainability over time, because what I always say is that when we have financing which relies heavily on the labor force, it becomes a pro-cyclical. In other words, during bonanza, a lot of money and a lot of expenditure. And when we face a crisis, the funding is scarce, and that leads to cycles which is pernicious, and the state has the ability to provide stability over time for financing, and for that. And we, of course, have a major discussion ongoing. The fund deals with a large amount of expenditure, and if there is a mismanagement of that expenditure or even corruption, that inadequate expenditure is very big, despite the fact that for the funds it may be a small percentage, but in actual money terms, we're talking of large amounts. And one of the problems that we face is impunity, and this is a difficult situation in the whole of Latin America, I believe. Neutrality has a lot to do, and this is heavily and I have read documents about the Mexican experience, because in Mexico they have a great discrepancy between formality and informality. And in informality, in Costa Rica, we have a very similar pattern. And the cost for the informal sector is low and very heavy for the formal sector. And this comes from the same logic, in the sense that we're a very unequal country. We have the formal world that lives at the level of the first world, and the informal world that involves a whole series of dynamics, such as, for example, they're afraid of approaching the Social Security Fund because the costs are extremely heavy to them. And therefore, we must achieve this neutrality to say, well, if you're in the formal labor world, your costs, your benefits will be considerable. And this involves credibility. And therefore, what I have tried to explain in several fora is that Social Security is not a tax, but so that it does not become a tax, it must be credible. Think about pensions. If you look at this objectively, pension is just a deferred income. I save today so that I can receive a pension tomorrow. So it's not a tax, but I must believe that that income that I am deferring deferring today will be received by me in the future. If I don't believe in my pension, then it just becomes a tax. But if I believe in my pension, it will become a deferred income. And that is interesting. Credibility becomes very important as an essential part of the conception of these costs, and even more so. And this comes from the narrative mentioned by Maria Luisa. If you construct an adequate discourse, an adequate narrative, in the sense that the state is not only forcing you to save so that you can have a deferred revenue in the future, but that that the state, in fact, by conducting a collective accumulation of savings, is capable of achieving greater incomes and safer incomes than what you as a person could obtain alone.
You have seen this. If you have, I mean, how the pension fund works is very clear. The greater the fund, more capacity of saving, because there are better results, personal saving, that we can level the situation. So that's something essential to me. To meet this promise, we basically have three promises. One is to improve services, control expenditure, optimize assets management, financial and physical assets, to manage hospitals properly, and also to manage our financial assets, because we have funds which this is a lot of money. They need to be invested properly, and in exchange we need to have two promises from society to us. One is to redefine more clearly how the social protection mechanism will be, so as not to be overburdened on the formal employment. There is a great informal sector which is not participating in the saving institutions, and so finally, one important part of the income come from the state, but in recent times the state hasn't had the capacity to manage that, and that creates a great financial instability. And we as the saving institution, our capacity to financially plan is weaker if the state doesn't meet with the promise that it has made. And so if the planning on hospitals, I can contribute to advice, and then the hospitals, etc. Well, that turns into more complex situation if I'm not sure about the money that I will be receiving in concrete terms provided by the Ministry of Finance. So the thing is to receive from the country, because I mean, say the Ministry of Finance needs to finally make the reference or what's the economic effort that the country is available to face. Thank you so much. Thank you, Alvaro. I think that we were all highly interested in the experience of Costa Rica, the saving insurance institution, and low costs, and the primary care, prevention, but also in having effective data of such a high coverage, more than 90% and reaching 100%. This is a clear demonstration that this is possible even in an unequal country, because it's still a Latin American country with the risk of rapid aging, something that is very important to consider. A point about credibility and transparency, I think that this is a clear message. If we want to reach to the social and fiscal pact, we need credibility, we need transparency. The citizens need to trust and that we'll have access to service of quality. And the need for stability and in terms of expenditure in health, that's very important. And finally, do not look at this as a tax. that's something very important. Thank you so much. And now we will continue with Miguel Fernandez Galeano, a specialist in health services administration from the School of Medicine of UDELA, the University of the Republic of Uruguay. He is consultant in health systems and services of PAHO. He is member of the Scientific Advisory Commission on Health Issues of the Medical Association of Uruguay, and he's a medical doctor in medicine from the School of Medicines of UDELAR. So, Miguel, you are recognized. Thank you, Simone. Thank you for the invitation. I will try not to make a presentation, but I will try to stuck to the 10 minutes that I have, making some comments in line with presentation of Maria del Carmen, and taking from Álvaro Ramos' presentation the idea that Uruguay and Costa Rica were very similar. We have a very similar health model, and many of the comments provided by Álvaro are applicable to reality in Uruguay. I will try to respond to the main message of this panel and what are the main transformation aspects to reach all these aspects that everyone, the government commitments want, that is to provide universal access to health. But we never find, or it's difficult to find, what are the main areas which deploy those contradictions. Maria Luisa was very broad presentation, what she gave, and she provided all the elements which are important here, but it's important to focus on the main elements. I think that the first important thing is the main message of this second seminar with the objective to go to a new welfare state. It doesn't say new, but I'm adding that word because we can have welfare state that has been conceived 40, 50 years ago, and not, I mean, very little in the region, but so much in the Europe. And so we need to discuss about the new role of the state here. And so to put the role of the state as a key element and to talk about welfare state and give a new meaning to that, I think that is closely related to what we are discussing here. That is, how can we reform the health systems? The second element, which is the most important one, is to put together social protection and health. I think that there's kind of parallel agendas. The reform of the health system is one agenda, and social protection is another agenda, but the discussion that the PAHO has had at the beginning of this century is something that we need to revamp again. And this seminar and Maria Luisa's presentation have taken those concepts again as something that is indestructible, to think of a transformation of the health systems. And this is closely related to what we always request from the health systems, that is to resolve three challenges. First, equity, access, funding, and health results, but without leaving aside the homogeneous quality, capacity to make resolutions, and dignity of services and benefits. And these two things need to be complied. Otherwise, we are going to have what finally Latin America has, segmented models, which are segmented by the socioeconomic differences, which could appear in different manners, and they are scattered, fragmented, because of there is a kind of a feedback between these two aspects, because the market logics, not considering health as an essential human right, and as a public good and not as a market product, and the health looked as part of the social welfare, losing sight of that is that makes that we can find systems which are not comprehensive or resilient and all the adjectives that we can put to the systems. So we need to go deeper and to analyze the problem that, according to my opinion, requires to get rid of that segmentation. First, the political guidance. Maria Luisa provided a lot of components at the end of the presentation where we have technician, institutional, official, how to transform our models. But I want to say that the key element is, from my point of view and my experience in the reform that Uruguay has gone through since 12 years ago, is the political guidance of the transformation, because the governments and health rector are the ones who determine the path and the road of a health transformation system. It's not a technical roadmap. And the second element, which is closely related to this one, to resolve the problems of segmentation, is the key element of joining compulsory public funds, no matter what the arrangements of each country. We could do it merging the contribution of the state and funds of social security with an additional contribution typical of a social welfare model where each individual contributes to the health system according to payment capabilities and receive from the health system according to the health needs. And this is not calling upon all the principles, but the definition of the Pan American Conference of Health, Ernesto Vascolo, is there, and this was defined in the year 2002, the definition of universal access to health and social protection with under these two basic principles, and the ones who contribute to the health systems according to payment capabilities will receive according to their health needs. So to, finally break this circle of segmentation, we need to resort to health authority and political guidance, strengthening the health system management. And to resolve the problem of inequity and sustainability of the system, compulsory public funds which restore the money to the lender according to the item adjusted per risk and social conditions, something that the Uruguayan reform has put into place. And to resolve fragmentation, the construction of health system networks that put at the center of the health system and not the demand at the center. The strategy of comprehensive networks of health systems is that the government goes within the system via faster tracks, and where the first level of primary care level is not the primary care. Sometimes there is a mix here between the primary care and the first level. One thing is the organization of the system, and the other thing is the strategy that mainstreams all the care level. But the first level plays an essential role, not only because it's the entry door to the system, but because a high percentage of health problems can be resolved there, but it's the one that is structured under a territorial logic, the relation and dialogue which are essential between social determinants of health, and to overcome the idea that the health services will give the response to the main challenges faced by the health systems and health system transformation. You said, Simon, that in the countries to invest health, they don't need to be rich to have a good health systems or equitable health system, and they're not magic recipe. Each country has to put this into their own context and the structuring, I think that is a good idea. I like this more than the word reform. Restructure means to work with what the system has under a strategic approach and what each country has, but with one single perspective, that is meeting the objective, that is universal access with quality, because it's not only to have access to the system, because sometimes we have systems that give you equal opportunities, but you're going to be in the waiting list. But we want equal opportunities to have services and benefits with homogeneous quality. So the ratio between quality and sustainability is something concrete, real, is not a set of purposes which are not articulated properly.
So that's, I'm reaching the end of my time. I don't know if I've been provocative, but I need to say that the Bayville Tower has been built for a long time. We have old wines that are, every time we begin, we put them in new vats. And what's all about here is how Latin America starts to organize based on its main priorities, the fact of reaching systems guaranteeing access. I no longer use the word coverage, it's access, access in the broadest and comprehensive meaning, so that in some way we may have systems that will invest below 6% of GDP. There's no way we cannot ask these systems to be achieved with low investment, but it needs to be above that, so that it's 6% of GDP, but with the prospect of organizing that in order to conduct institutional arrangements with public mandatory funds. Uruguay reached 80% of coverage in Social Security, around 80. It has levels of informality that are low for Latin America, but still we don't succeed for informal workers to be in our FONASA. It's a public mandatory pool fund, a virtual one, harmonizing financing with equity, because you contribute according to the payment capacity of persons, and that harmonization has as main target the idea of responding to a plan of comprehensive demandable benefits, not a basic package, because universal coverage is not a basket, it's a set of demandable benefits, and that means thinking about equity. That more than a presentation, I take the presentation of Ramos. We are very similar, we've done similar things, but we need to see how Latin America assumes challenges and unification or elimination of co-payment. We need to delete taxes on disease, which are co-payments. The more you need the health, the system invents mechanisms of mercantilization of health that call for specific payment. Elimination of co-payment. I'm glad that in Chile you have already population groups that will have zero co-payments. With that, you build a true path towards a universal, comprehensive, and resilient social protection system. Thanks. Thank you, Miguel. It's not by chance that we have Costa Rica and Uruguay sharing your experiences, because the progress and lessons are many. It takes time to set up all these systems. There's a lot of history, and you called us to build a new welfare state, to work towards harmonization, bringing together social protection and health, something Maria Luisa had already highlighted. No to segmentation, that's the main message. And your call to benefits having certain homogeneity in accordance with the dignity of citizens. Your call to political leadership and the idea of paying according to capacity and receive according to necessity or need. That's at least 6% of GDP. And your final call to eliminate copayment. Thank you. Very useful message, concrete message towards where you need to go based on experience. Thank you. And now we have the pleasure to recognize Ernesto Vascolo. He is interim head of the unit of Paco. He's an economist. Among his degrees, he has a PhD from the University of Buenos Aires, a post-PhD from the École Nationale d'Administración Publique, and academically, he's a researcher in CONICET of Argentina. And we've had the pleasure to have him to have his contributions in ECLAC Paco bulletins. Thank you. You have the floor. Thank you, Simonia and colleagues. I'll really make an effort to convey in 10 minutes the contributions. It's a special gift to speak after Miguel. Not only is he my colleague, but also my friend with whom we share not only ideals, but also ideas of how to take forward all these ideals. And also congratulate the organization and trying to find a flow and alignment with the past panel, and also in accordance with the presentation of Dr. Fitzgerald. So, with the idea of supplementing and not repeating in spite of common ideas and ideals, I would like to start with some key concerns, and one of which is that when we speak of health in social protection systems, we are seeing how it works, how social security works in health in particular, our segmentation, which is we repeat as part of a structural problem or institutional problem, calls for zooming in the dynamics, not only in countries which are iconic, like examples, the cases of Costa Rica and Uruguay, but also the diversity of cases where social security is one of the elements, or rather a subsystem within the health system, and how it works. What's the working dynamics? This is another point I thought of relevance to articulate it with the previous comments of Miguel, where he was emphasizing the need to link the technical with political analysis, not only because it means interpreting technically what the technical object that we need to address, but interpret that transformation processes are led, triggered, politically guided. That is, institutional changes are monitored in some way. Here, I'll start with a rapid retrospective historical analysis when we speak about the role of Social Security in our region, Latin America and the Caribbean. Firstly, it is linked since the 40s to the 70s to industrialization processes that gave rise as a framework for regulating the labor market and for the search of rights by workers provided health coverage in an emerging manner. Social security systems begin to structure at different paces and different outreaches depending on the level of development and formality of the labor market of different countries. We can say it grows, I would say. Not all countries are crossed by these different landmarks that we can recognize, that is, different moments where we can describe ways on how Social Security is articulated or changes in the health sector. The examples that somewhat fall out, or when we see the examples like Costa Rica of this continuous cumulative expansion or progress of coverage, it would seem to be less immune to different historical moments that generate moving ups and downs and backwards and frontwards. In other countries, the 80s are caused by reduction of contributions or levels of contributions and privatization intense, more or less, in Latin American countries more than in the Caribbean. Not only that had countries like ISAPRES in Chile. These were cases that guided processes of Social Security reform, including the private sector in managing those resources. Even during the 90s, a social risk management perspective, including market mechanisms in the infrastructure for Social Security, we could say in some, they expanded that rationale to not only Social Security, but health systems in the last 2 decades now. As Miguel said, and Dr. Fitzgerald in the past panel, some have been caused by a dynamics of strategies seeking to guarantee universal health. And this is one of the topics I would like to go deeper into, because not all countries have had the same history, the same background, the same change dynamics. Of course, they all start from a contributory financing structure, or what is it available in each one of the countries to be structuring and financing its own health system. In one extreme, we speak in one extreme, like the case of Costa Rica, much more based on contributions of the labor market. And on the other extreme, you have Brazil and many other countries of the Caribbean, where financing fundamentally stems from domestic government contributions or tax contributions from the government. In the middle, we have a large range where we have contribution of Social Security and public sector, and there we have very diverse cases of organization of Social Security. I will go into this concept of reform processes. And we need to consider fundamental dimensions to describe the different rationales of transformation processes. I won't dwell in each one of them, but I will mention that one of the elements, it's very important to remember that neither health, nor social security, nor social protection are islands within the social structure of countries.
And one of the fundamental elements that has to do with these elements has to do with the relationship between the state and the market, something that Miguel conveyed very adequately, because he was saying that in order to continue to make progress, taking decisive steps towards universal health, we must also think about the reconfiguration of a new welfare state. And this is what I also wanted to comment. And one of the elements that came across in the comments by Uruguay and Costa Rica is that time matters. There are no reforms overnight. No reforms are made that are not linked to prior histories or to prior institutional structures or to the prior stakeholders that have existed always. The graduality of those processes is fundamental. And finally, this that has to do with the relationship between the political process and the institutional process. A lot has to do with the stakeholders that are involved in each reform. It's impossible to think about characterizing reforms and analyzing and the analysis of its results only with the political color of the governments in office, but we must also think of the set of allies that form part and that are integrated into that agenda of processes. The collective action underlying those institutional transformation processes. Normally in PAHO, what is it that we do when we analyze the situation over the past 2 decades? Well, we analyze on the one hand, and I say this in a very synthetic fashion, reforms that are primarily focused on the public sector and in an increase in access, but with a primary healthcare perspective, but at a sub-national or even local level. And on the other hand, we also have important reforms that are focused on social security, that have used social security as a platform to expand coverage to the whole population. In part Peru, but clearly Colombia, Uruguay, Dominican Republic, and I place Uruguay in this place, but considering Miguel's comments, one could clearly say that they also share characteristics of comprehensive reforms, because despite the fact that they took into consideration the social security components, the solidarity component means that they deserve to be placed at the same level as Canada, Costa Rica, or Cuba, where they come much closer to the characteristic of more comprehensive systems. Different reforms have made progress. Those that have to do with more local or provincial perspectives have basically improved access, but in a heterogeneous manner. They rely on the progress and the dynamics of each one of those experiences. The other reforms that have been much more, let's say, institutional in nature, have decisively increased coverage conditions, complete assurance or practically complete assurance to the whole population, but involving important challenges in terms of access, solidarity, and also in terms of implementing these reforms with a primary care perspective. Each one of these reforms could be characterized by the type of stakeholders that have been incorporated. The first one, the ones that are focused on access, have implied the involvement not only of political stakeholders and politicians as stakeholders, but also teams of health professionals and social movements who are the protagonists of this process. And in one way or another, the engine for change, the underlying engine for change of these have to do with transforming the care model. On the other hand, reforms that were based primarily on reforming the assurance model, and because of lack of time, I cannot break down and distinguish the different characteristics of each country. But we find private insurers as important as stakeholders. With the case of special case of Colombia and the Dominican Republic form part of this. No, none of them are profit-making. We would also have to include Chile within these characteristics, but that dates back to the end of the 80s with this logic of competition between different insurers. And this is very important because the private sector that 2 decades ago, we could feel that when it came to assurance, they provided around 7 to 8% of total financing. When we analyze practically 2 decades later, the increase in the share of the private sector as managers or administrators of resources in the health sector, that has increased significantly. But what is even clearer than that, and this answers or responds to the logic of transformation processes that I commented beforehand, this increased decisively in those reforms that used social security as a platform for transformation. Here we see the types of institutions in each one of these countries. Obviously, one of the key elements that must distinguish or set apart each one of these specific situations, and in view of time, I cannot explain this in detail, is that third element that Miguel referred to as a pillar that has to do with the different mechanisms that guarantee solidarity in the allocation of resources. But these transformations were also institutional, very important institutional transformations. In each one of these countries, we have experienced a relevant increase of new agencies, new regulation mechanisms, especially derived from reform processes in order to regulate the operation of private stakeholders within the system. And to the extent that these transformation processes changed with delays, regulation entities came behind in one way or another, trying to tackle the market failures of the operation of these health systems. Of course, when one analyzes the sphere of action of these regulatory agencies, the key element is social security. In many cases, not integrated to the rest of the system, a little with the system, and even less so with the private sector. And that weakens one of the fundamental functions of the system, which, as mentioned beforehand, has to do with the capability to lead this process. Another important element is that despite the fact that there have been regulatory mechanisms linked to the operation of the insurer as such, the relationship between that insurer or purchaser of services and the provider, something which should have an impact on the way in which services are rendered, has in general terms been very weak. And I would like to close with sharing some data with you. What is interesting when we look at coverage conditions, and now I understand why perhaps Miguel doesn't like to talk about coverage so much. Well, because despite the fact that the most important progress in many of these countries have shown merits that are very important in order to increase coverage. The increase of coverage has not necessarily led to improvement in access conditions, but even less so to the inequalities inherent in access to these services. And therefore, the increase in assurance and the coverage of assurance is not necessarily a factor that is capable of predicting so that we can transform the way in which services are provided. Of course, in ideal terms, and considering different contexts and with a territorial perspective and within a primary healthcare perspective that seek to reduce access barriers to the population as a whole. And even when we analyze different types of reforms, it is clear that the reforms that focused on a change in the care model have been far more effective to reduce access barriers than those that exclusively focused on reforms of assurance. And this is the end. And somehow this slide seeks to summarize the fact that when we talk about social security, this is a very important issue in order to describe the dynamics of transformation processes experienced by the region, undoubtedly so. However, despite the fact that there was important progress, we also face challenges. And those challenges are not only related to those associated to guaranteeing greater solidarity in the mechanisms to obtain resources, and we not only face challenges related to the mechanisms to regulate the private sector, undoubtedly so, but we still face very important challenges in order to guarantee equality in access to health services. Thank you very much. Thank you, Ernesto. Excellent to have a complete regional outlook. We had heard the cases of Costa Rica, Miguel with the case of Uruguay as examples, but here we thank you for sharing that historical perspective, which is always so necessary when we think about the time when people were fighting for rights in the 70s, and after we experienced the 80s privatization, in the 90s the social management of risk, and now we advance towards universal health. And you show us how there is no one single model. The slide on sources of financing is very clear, much more geared to social security, general taxes in many countries. And what is also very interesting is what is the reference that the slide makes to the reforms, the logic, the characterization, where there is a greater focus on increase of access, expansion of coverage, and those those reforms that are much more comprehensive, and figures that contribute enormously to this debate. And that figure that you show us at the end in terms of the increase of the private sector as a manager of resources, all that are very important aspects that have to be taken into consideration. And likewise, the fact that there is a new role played by regulatory agencies. So thank you very much. And now I would also like to mention that there has been a lot of participation and many online comments. We have more than 130 people online connected to this session. There have been different comments that we thank. Some have highlighted, for example, the importance of strengthening health actions, promotion, protection, rehabilitation with quality and timeliness, the role of local health teams that are, at the end of the day, those that take health to people. And what is also important is participants say the preventive actions. And now I have the tremendous pleasure of introducing Berta Luz Pineda. She is coordinator of climate change, economics, and health and social inequality of the Andean Health Agreement, Convenio Hipólito Annes. She is a Colombian sociologist and has experience in social projects, in interculturality, health programs, and international policies and health sovereignty. And she is a great promoter of health in Andean countries. So Berta, you have the floor. Well, a very warm greeting on behalf of Maria del Carmen Calle Dávila, who is Executive Secretary of the Andean Health Entity. And we thank the invitation to this very important seminar. We would like to deliver a presentation benefiting, and I would like to introduce to you the Andean Health Entity that was created in 1971, involving Bolivia, Chile, Bolivia, Peru, and as a mission, as a vision, we have to articulate and promote public policies, plans, projects, research, exchange of experiences, technical cooperation initiatives in order to struggle against inequalities in health We work based on a strategic plan, and it is what is very important is the work that we conduct with Andean committees, 18 Andean committees comprised of delegates from the ministries of health of the 6 Andean countries, 8 working groups, 1 Andean network, and the Andean intersectorial working group to struggle against inequalities, and a technical coordination team. Of course, we have conducted this work with partner associations such as ECLAC and the ones that you can see here, and the maximum authority. It takes important decisions and resolutions in order to advance towards guaranteeing the right to health with and especially an integration process that began this year. We hold 2 extraordinary meetings with ministries of health in order to deal with vanguard issues, and we participate in all processes related to the Andean integration system in the different meetings with the Andean system, and the Andean system of integration recognizes our entity as a reference point for health and its commitment in order to support everything that is related to the strengthening of and the implementation of the 2030 agenda.
I should highlight, Dr. Ari, highlight the need to set up a joint work with all the organization of the systems, keeping health at the center of the policies is also very important. The activities that we carried out, that is meetings with the national authorities to approach the different priorities. Since 2020, today, the topics has been focused on response to COVID and how to strengthen the integration system. We are working in a new strategic plan for the period 2023-2030. These are closely in line with the SDGs, and the main purpose is to recognize health as an essential aspect for development, overcome inequalities and inequities in health, and to put forward the right to health. We have the main premises, the ideas expressed by Antonio Gutierrez, where he emphasized the need to bridge gaps, the gap to the peace, the climate gap, the digital gap, the gap between rich and poor. So we have many challenges that we're working in this health Andean organism. The pandemic has surfaced many problems, as you have said. Mortality, excessive mortality in the region is a demonstration is the need for real transformation. The transformation in the health sector is evident, makes evident the idea of overcoming inequality. We have economic crisis, social and political crisis, and planet crisis. The planet crisis is related to climate crisis with biodiversity, and so the water crisis also show us the way to relate among ourselves and the nature that we need to transform. So health should be at the center of the different policies, social justice and environmental justice in the midst of a welfare state. Universal topics, protection that are sustainable for health and for common protection, integration, cooperation, regional solidarity, international solidarity, and of course, health sovereignty. That means that this crisis opens an opportunity for transformation. Health needs to be at the center. Care for life and health needs to be at the center. So the need to strengthen the work to perform and take actions of the social determinants in the region, such as good living and rescuing the ancestral knowledge and with the different approaches, but it's also a call for the need to be in line with the rules of the game, and emphasizing the need to continue strengthening the general observation number 14 that says that every human being should enjoy at the highest possible level of health to allow living with dignity. So we need to meet with this. As I told you, the general observation 14 states some elements to guarantee the right to health since year 2000 in response to the social pact in relation to rights, interculturality, quality, participation in decision-making processes based on the community processes, accountability, and these are elements which are required to comply with to guarantee the right to health. This has created broad debate with the development of strategy to have an economy and development, taking care of the planet, respect for human rights, economic, social, and environmental rights. We are working with concertación against inequalities with delegates of ministries of health of 6 countries in having a baseline on the social inequalities, creating a conceptual framework and strategies on how we could overcome the multiple inequalities and intersectional inequalities. We are working in an Andean policy to face social inequalities and health, and I would like to take this opportunity to thank ICLAC, PAHO, WHO, and the delegates for participation in the Andean board. To achieve a universal, resilient, sustainable health system, it's important to have a new epistemic horizon with new social debates and political commitment. And we always say that without assumption, there are no rights. It is essential to have the political commitments in all this endeavor. We have stated the need to continue working to strengthening horizontal cooperation, South-South cooperation, and from those guidelines to debate with all the society about the health horizon that we all deserve, to break the narrative of the current system and to continue going forward with research to promote and build all the different frameworks. And one of the things, essential things, is that we need to promote and build all these categories to rethink about our experiences and health systems. Our health systems have copied theoretical conceptual framework of other systems which are subject to different realities. So it's very important to rethink our own, and the transformation horizon of our technologies put more emphasis in overcoming poverty, the political, the academic, cultural, economic differences. It's important then to rebuild hope, but also to consolidate hope. We have a lot of problems and structural problems, material problems. We assume that our institutionality has no capacity to make public goods universal, and that the state are facing economic problems, but we cannot create a concept behind the problem. So we need to rethink and revitalize that hope with solidarity, with political allies, and so adversity of the financial medical complex need to make a call to solidarity, because we all together can be stronger. We need to set up partnership for work and cooperation. Thank you. Thank you, Berta, for the reporting about the history of the Andean Health Agency Strategic Plan by 2030. We all together are stronger. So, and the inequalities, gaps from considering rights, but you also mentioned the COVID, apart from the comprehensive outlook of the live, and you connected this with the good living in the Andean region, the ancestral knowledge, how we relate to indigenous peoples aspects, which are very important, and your message and the political messages of different agencies about the need for cooperation and the need for funding, South-South cooperation, and also sovereignty, health sovereignty from ICLAC. We have also cooperated with CELAC to discuss and promote health self-sufficiency in the Latin American region. But now, last but not least, we are going to listen from Michele Gragnolati, Manager of Health Practice of Latin America and the Caribbean to the World Bank. Michele is economist, graduated from Bocconi University in Italy. He's got a diploma in international management in France, a master's degree in population and development of London School of Economics, and also a PhD in demography of Princeton University. Michele, you're recognized. Thank you so much, Simone. Good afternoon and good evening to everyone. I would like to start by thanking the organizers for this invitation. I'm very happy to be here with you. And I'm very thankful also to Maria Luisa, Berta, and the previous panelists for their presentations and reflections upon the health systems status in Latin America and the Caribbean and the challenges that you are all facing, including equity, which is characterizing the region in a very special manner, which compared to other regions in the world has been really inspiring to listen to each one of you. We are facing interesting times for the health sector. I think that today more than ever, because of the pandemic of COVID-19, has put us all, the ones working in the health sector, in a reality that we don't have acceptable or unacceptable health conditions, and we are clear that the countries depend on the health of citizens. At the World Bank, the support of the health sector over the last 2 years has increased dramatically. Just to give you a couple of numbers, the funding that we had for the health sector in Latin America and the Caribbean increased from 12 to 32% over the last 2 years. And now the World Bank is lending about $3 million for the health sector and to Latin America, which compared to the needs that exist here is not so much, but for the standards of the World Bank is a very important figure. And the surveys in almost every country in the world, including Latin America, have demonstrated that health has been put at the top priority for all the citizens. So, on the other hand, this has been developed in countries that, as we heard, they have a very significant inequality since before the pandemic. And the effect of the pandemic after 2 years has been devastating in different communities, and with political, economic scenarios in front of us, which are really uncertain, but it is globally.
So in that context, we have prepared a brief presentation insofar as vulnerabilities of Latin America and the Caribbean, and reduction of these major social and economic inequities of the region. The presentation is in English, so I will go back to English.
Has already been said by the panelists of this session and earlier in the day. But you know, you cannot start but looking at the inequalities that the Latin American region is characterized of, you know, and then, you know, when I was working in LAC 20 years ago. I went to work in Eastern Europe, and then I came back to LAC, and I was shocked by what can become, you know, the default. You know, but LAC has a huge inequalities with in health and human capital outcomes. And then, of course, Haiti is the outlier on whatever indicator you want to take, but everywhere you see that there is a strong correlation, and Maria Luisa showed that very, very clearly. You know, there is correlation between GDP per capita and any health indicators, and most importantly, there is a huge socioeconomic gradient in socioeconomic indicators and health indicators. And on the right side, you see the graphs about adolescent girls who have started childbearing. And, you know, in about 40% of girls with primary education, or in the poorest quintile in Guyana, the Dominican Republic, and Honduras, have started childbearing before they were 19, you know, 4 out of 10. You know, and the figure is considerably lower, and sometimes often very low, among girls who have started higher education or live in the richest quintile. That of a teenage pregnancy is fascinating for me as a demographer for Latin America, because, you know, despite a very rapid change in the total fertility rate, you know, teenage pregnancy remains very, very high. Let me go to the next slide, and we know that the impact of COVID has been devastating for all socioeconomic groups, and as was said earlier, even more so in LAC. I think it was you, Simone, who said that 27% of deaths were in LAC, while the region only covers 88% of the population. However, not only the access and quality of services were lower at the beginning of the pandemics for the poorer and more vulnerable groups, but the impact has been larger during the pandemic. And now we see there has been some recovery. This graph is from Peru, which has the most incredible information system through household services and administrative data. And we can already see there has been a recovery, but still the gap in access to formal healthcare for population with illness is higher now than it was before the pandemic. The question about what to do is what people, policymakers, academics, everywhere working on health, people are asking for, and, you know, it will keep many of us busy in the next few months. And it was very interesting to listen to the framework that James presented in the morning, which is centered around primary healthcare and again, and finally, public healthcare as well. These graphs are taken from the OECD World Bank Health at a Glance LAC, the edition of 2021, and has data before the pandemic. A new edition is going to come out at the beginning of 2023 and will capture the changes introduced by the pandemic. But we see many patterns, but I want to highlight two here. First is that while expenditures in LAC grew during the pre-pandemic period, they remained well below those of OECD countries and were more dependent on private spending. You know, Ernesto made it very clear that it's so difficult to have make a general statement, but I think this is on average true. At the same time, you know, spending on health was about $1,000 per person in LAC, which is 1/4 of what is spent in OECD countries, even after adjusting for purchasing power. And as a percentage of GDP, this accounted about 6.6% in LAC and 8.8, about 9% in OECD countries. You know, this is interesting because you see that, you know, the combination of government and compulsory health insurance represented an average of 54% of expenditures of health in LAC against 74 in OECD. So the composition, not only the level, but the composition is very different. The second point is related to that. And clearly, low government and social security spending insurance means that the population has to rely more heavily on private insurance and more significantly in the LAC region on out-of-pocket expenditures. You know, the 34% of all spending in LAC in 2017 was out of pocket. You know, that's the most inequitable and inefficient way of financing healthcare expenditures. And as always, the differences across countries are huge. On the one side, you have Cuba, Argentina, Uruguay, and Colombia, and on the other side, Haiti, countries in Central America, especially Guatemala, where tax collection overall is really very, very low. The question about you know, what is the optimal recovery path? That is, you know, what health policy mix can produce changes that are more effective, more equitable, and more sustainable in the shorter term is even more critical, because the recovery of the health system is happening at a time of economic and fiscal uncertainty. This slide shows projections that were made at the World Bank on per capita government health expenditures according to different scenarios about how much governments will be able and will want to increase the share of the budget that goes to health. And there are 4 scenarios, and you can look at the assumptions on the right side. I just want to talk about what we think is the most likely scenario, which, you know, given the surge in spending for health observed during the past 2 years and the many competing priorities that have been put on hold during the pandemic, we see that governments are sort of starting relaxing attention to health spending, and gradually but consistently going back to very important priorities that have been left behind. And we see that indeed the most likely scenario we expect in the next few years is that governments will choose to hold the pre-pandemic share of health in government constant instead of continuing what would have been if you wish, a more natural pattern if the pandemic had not occurred. Of course, we see also in some countries this is not happening, and indeed the choices have already been made to increase the budget that goes to health, as well as starting making some of these very difficult changes that the panelists before me have highlighted, that are very difficult but are really truly necessary to make sustainable progress. This has been said in different ways by everybody, and it's a clear characteristic of health systems in lack. The huge segmentation and fragmentation of health systems is at the heart core of inefficiencies, inequities, and all the risks associated with health. And the presentation of Ernesto actually was very, very helpful to understand the different steps of the reform or the vision for health systems in LAC. The reality is that health systems in LAC for most countries have not adjusted to the ground reality over the last decades, that only a very small proportion of workers still have access to formal employment. This expectation of full employment of the 40s, when the health systems were set up, just didn't materialize. This of course has many implications, and we have already heard about them. I just want to here again highlight two. First, this is behind inequality and will continue perpetuating inequality. So if we want to address inequality, we have to take the fragmentation and segmentation very, very seriously. And the second is that since as we were saying, the formalization of the labor markets is not advancing, different resource mobilization and pooling arrangements are needed and have been developed, as again the presentation of Ernesto showed very, very clearly. Each country will have to develop its own solution, and there have been many attempts, some more successful than others. What comes next will have to be very carefully planned and designed, and I really liked the reference of Miguel to the conducción política de la transformación. With just a technocratic approach will not make much of a difference. And then, just to conclude, I'm showing a slide that many people are familiar with, and shows that indeed, despite decline in out-of-pocket expenditures during the past couple of decades, LAC still has the highest proportion of population spending that is a catastrophic share of their income, of its households on health, 51.1%. This is for 2015. The World Bank, jointly with WHO, is now updating the estimates, and it will be interesting to see what has happened after the pandemics. I'm stopping here. I thank you all for your attention. And if there is time, looking forward to the discussion and certainly to staying in touch. Thank you.
Muchísimas gracias, Michele. Bueno, partiste dando una cifra importante del apoyo del Banco Mundial al sector salud de la región, $3.000 millones, igual a un aporte. Y el hilo conductor, por supuesto, de las desigualdades en salud. Tu gráfica sobre la fecundidad adolescente fue muy comentada en el chat y de hecho, digamos, es un tema que desde la CEPAL siempre le ponemos énfasis porque un indicador
size because it's an indicator where indeed we have far greater levels than what could be expected for a region with this level of income. It's a complex issue. It drops, but not very significantly. So this is a major issue that has to do with inequality, and that implies serious problems for education and for the labor inclusion of women. What you said about expenditure is also very interesting, and you have really pinpointed the expenditure of households that is of great concern within a context of great inflation and poverty, and in addition out-of-pocket expenditure. And you have also mentioned the various scenarios, and countries will continue to increase this. That's bad news for families, and that is why we need to advance towards the universalization of health. And another important message is that segmentation is inefficient. We are running a little bit late, but obviously we want to at least have a brief comment, maybe just 1 minute from each one of you, a final message, something that you want to say, something that you need to say. So we'll use the same order. Maria Luisa. Thank you, Simon. I thank the panelists for their fantastic presentations that obviously contributed enormously to the debate and the discussion, and it's marvelous to have you all here during this last panel of the seminar before we move on to the closure. I would like to very quickly highlight some points that were mentioned via the panelists, via practically all the panelists, the issue of advancing towards greater levels of solidarity in financing, and because that indeed would lead us to overcome segmentation and inequality problems that have a tremendous impact on the health of the population in our region. Obviously, the issue of financial sustainability, and here I highlight what Alvaro Ramos mentioned during his presentation, that despite the Costa Rican case, the importance of informality, which is a phenomenon that impacts most countries in the region, is an element that has to be taken into consideration. And finally, of course, what summons this panel is the importance of having good intersectorial policies, strengthen social protection systems and health systems. We know that the social determinants of health are responsible for a major part of inequalities in health. And in that sense, we need to strengthen the link between both, as I mentioned in the comments made by panelists. All this accompanied, of course, by a fiscal social agreement that provides us with political and financial feasibility to the transformations that health systems in the region require. So thank you very much, everyone. Thank you. Thank you, Maria Luisa. Now, Alvaro. Thank you very much. It has been very interesting to listen to the different panelists, the regional outlook that we have with regards to health. In my case, I would simply like to reiterate this profound concern. In Costa Rica, we have a good level of coverage, and therefore the discussion has focused on quality and costs. And well, especially because there is always pressure in terms of outsourcing and privatizing some of these services, and despite the fact that that is a factor that could be taken into consideration in order to cater for some emergency situation. For example, our waiting lists post-COVID became very lengthy, and therefore under those conditions, in order to shorten those waiting lists, perhaps outsourcing could of specialists and so on could make sense. But in general terms, universal coverage has to focus on primary health. It must be a high quality care, and it must resolve many issues. And I would like to add something that I hadn't mentioned before, and that is an important technological component. In Costa Rica, in this fund, we have developed technological platforms that have become practically universal in order to generate the management of records, and references and so on. And that is fundamental for citizens to perceive an excellent health management, because we acquire a better profile of what communities and populations require, and also individuals need. And therefore we can provide a greater, better care at a lower cost. Thank you. Thank you, Alvaro. We'll offer the floor to Miguel. Thank you very much. Very interesting exchange. I believe that it's very good to generate dialogue in order to think about alternatives and to deepen reform processes that are underway. Reforms are never end. Reforms are permanent constructions, and the transformation of health system is determined by many factors, and therefore it's always important to be permanently discussing this. And in those places where universal coverage has faced difficulties, well, I believe it is what is very interesting is the concept of graduality and strategic approach in the construction of that. In the construction of these reforms, we cannot think of reforms about the objective that has to be reached, but rather how to build a roadmap based on the capabilities that each health system has, and being very clear in terms of what are the principles that we have to work with. If the objective is equality, quality, and sustainability, well, we have to see how we can guarantee that within the concrete context of each health system. And I forgot about an issue that I will simply mention very briefly, and that is the issue of health in the 21st century, because the component of sustainability also involves how to respond to the demand of the rational incorporation of technology that is introduced by the medical industrial complex, and which is a factor that will and is already radically impacting the sustainability of systems. So I think that we must debate this issue. And on the contrary, the creation of public funds, mandatory public funds, will contribution. There is a whole debate there that 10 years ago, ECLAC put on the table, and which is a relationship between what is contributory and what is non-contributory. That is something that must be in our debate. There is no equitable health system that is only contributory in nature. Either states contribute to solidarity, and in that contribution to solidarity, make sick people be financed by healthy people, that young people finance the elderly, that those that have more money finance those that have less money. Without that triad of solidarity, there are no universal systems or equality in the health system. Please, I apologize for being so schematic. You are forgiven, because all messages related to solidarity are very important. Ernesto, thank you for the invitation, for participating in this debate in very personal terms. I must say that I truly enjoyed this. So that, in the first place, I had a very good time. I felt that we were jointly building this collective dialogue. Secondly, I feel it's very important. What is very important is this initiative of placing health and how it articulates, how it is linked to social systems. And that not only is the result of the organization of social security, and obviously this has to do also with the regulation of the labor market and the social rights in terms of how we built, consolidated, and universalized this in countries and in the region, but also pensions, education, and what we always mention, which is the need for an intersectorial approach to deal with the social determinants. And that leads me to reinforce that we're also discussing the role of the state, not health as an island. Please excuse me for being repetitive, but the relationship between the state and society, and that is a fundamental element enabling us to interpret reform processes. And within that framework, I haven't had time for this, but I think this was mentioned in one of the initial presentations, but this has to do with the PAHO agenda of essential functions of public health. That is something that we must mention, collective in public health interventions as part of the agenda to transform health systems and strengthen state capabilities in order to undertake interventions and guarantee the right to health for the population. And lastly, what is always present, and sometimes it's not easy to bring this into this level of high-level discussion, is results. How to try and highlight the different types of results derived from these transformation processes. And I refer to the results of health commissions for the population, not only as a context that is outside, but as something that has to form part in one way or another of the analysis of what was previously mentioned of the social determinants. The health sector is unable to introduce substantive modifications without being linked to the rest of social policies. Thank you very much. Thank you, Ernesto. Berta. Well, on behalf of the team of our team, we would like to congratulate ECLAC for this important event. Necessary reflections, beginning with the title of the event that emphasizes the need for social security and equality. We want to remember that health is a fundamental human right for the exercise of all the other rights. Every human right has the right to enjoy the best possible health that enables that person to live decently, and therefore is essential to strengthen regional integration and cooperation and South-South cooperation, and to advance in the right to health implies making headway in terms of just social and environmental justice and overcome unfair inequalities. It's necessary to promote and build other frameworks in order to rethink our problems. And above all, it is fundamental and necessary to value the cosmovision of our peoples and their experiences. I call upon solidarity and on our slogan, together we are stronger and together we will get further, we'll advance further. Thank you, Berta. Michele, well, I've got nothing else to add. I would like to thank you all for the invitation. It has been very interesting and very useful to listen to the experience and the knowledge of others, and also to see that there are successful experiences in the region. Uruguay and Costa Rica are examples of that, and there are many others, of course. A lot has been done, and there is still a lot to be done, of course, but thank you very much for everything. Thank you, each one of the panelists. and all participants whom we ask to remain connected. We are running a little bit late, but there was a lot of content, and now we will continue to the closing session. And I would like to offer the floor to Leonardo Ferreira, who is Subdirector of the ILO for Central America, Haiti, Panama, and Dominican Republic. And once again, a greeting for everyone. Thank you very much. Good afternoon. My greetings to participants. We are presently 128 participants. It has been a very intensive working session involving 3 days and different sessions and dialogues. And I have the honor now to act as moderator of the closing session of this very important regional seminar, the second regional seminar.
This session focused on opportunities to strengthen social security systems in a context of uncertainties. In this closing session, we have the participation of Mr. Alberto Arenas de Mesa, Director of the Social Development Division at ICLAC. Alberto is a PhD in economics from Pittsburgh University, has been working at the Ministry of Finance of Chile, and he was director of a budget of the Ministry of Finance of Chile. And in that capacity, he led for the tax reform in 2014 as director of budget. He led the structural reform to the pension systems in the year 2008 and executive secretary of a committee of ministers for the social security reform. He has written 4 books and more than 30 publications related to fiscal policies, social protection, and pensions. Those publications have been made and international agencies such as IDB, ICLAC, and others, as well as a specialized review. In this closing session, we have also Feliz Saqueo, more than 25 years experience in as a manager and advisor to different projects funded by the Minister of Foreign Affairs of Italy, Peru, Tanzania, Tunisia, and Nicaragua. Since 2007, he's been working in the headquarters of the European Commission in Brussels, and he has been there since 2016. And 2019 as head of sustainable energy, climate change, in the Directorate of International Cooperation and Development. In June 2019, he was appointed as head of the regional programs for Latin America and the Caribbean, and at present is head of the unit in Mexico, Central America, the Caribbean, and regional operations of the General Directorate of International Association of the European Community. The third panel member, Manfred Habig, he is coordinator of technical German cooperation with ICLAC, has been in charge of 2 regional projects on the urban connectivity, sustainable, inclusive urban cooperation since 1989. He has been leading the international business with sustainable development, social entrepreneurial responsibility, promoting renewable energies and energy efficiency. He has done research in rural development and livestock programs. As I said, this is the last session, the closing session. But I think that we still have opportunities to listen from these 3 panelists who will enrich the dialogue that has taken place in this second regional seminar. I repeat that the theme of this closing session is opportunity to strengthen social security system in a context of uncertainties. And we have Alberto Arenas de Mesa in this virtual modality, and in the case of representatives of the European Commission and German cooperation, as panel members, they will participate with a video, and due to the time difference, they were unable to be online. So Alberto, you are recognized. You have 10 minutes each. Thank you. Good afternoon, everyone who have been with us in this closing session, and has been throughout this second regional seminar on social development, which has been focused on social security and the opportunity that the region has to fight inequalities and make progress towards welfare states. And I would like to start with the cordial greetings and thank you, Leonardo Ferreira, Deputy Director of ILO for Latin America, Haiti, Panama, and Dominican Republic. I would like to also greet and thank Felicia Saqueo, Head of the Unit for Mexico, Central America, and the Caribbean, and Regional Operations of the European Commission, and Mr. Manfred Habig, the main advisor to the cooperation program ICLAC, BMZ, GIZ. Thank you to the ILO and PAHO teams for the collaboration that we have experienced during the organization of the second regional seminar on social development, and for your valuable contributions in the different panels that have taken place during these 3 days. We want to thank the strategic cooperation provided by the German cooperation and the GIZ team. And from a broader perspective, the reflection related to universal social protection, which is especially reflected in a project overcoming the consequences of pandemic of the COVID-19, funded by BMZ and the cooperation to ICLAB, but this is involve many other bodies. So thank the support for the development and transition of the European Union, especially the project for social protection and vulnerability, and the different exchange agencies and opportunities that we have had with all of them. I thank you very especially the Social Development Division's team of ICLAC, who enthusiastically has been behind the organization of this event, specifically Claudia Robles, who coordinated all the activities, and together with Maria Luisa Mariño had been responsible for this regional seminar on social development. And also the different colleagues of the other divisions of ICLAC, and especially the conference, STIG, the interpreters who have cooperated in the different activities. And special greetings to our audience who have been with us on virtual mode from 22 countries from Latin America and the Caribbean. Antigua Barbuda, Argentina, Bolivia, Brazil, Chile, Colombia, Costa Rica, Ecuador, El Salvador, Haiti, Honduras, Guatemala, Mexico, Dominican Republic, Panama, Paraguay, Peru, Puerto Rico, St. Kitts and Nevis, Suriname, Uruguay, and the Bolivarian Republic of Venezuela, apart from the participants from Germany, Spain, and the United Kingdom. Over these 3 days where we have had dialogue, we have had a valuable opportunity to discuss about social security systems in the region, reflecting upon the main challenges the countries face in this historical opportunity to implement necessary transformations to the pension system as well as health systems. To make progress and consolidate the warranties for the social, the rights the population is entitled. We have had the privilege to listen different panelists, and we'd like to thank you for sharing your experience and comments about Social Security in the region, and having the pleasure to listen to representatives of the governments of the region, as well as people from the academia, civil society stakeholders, and representative of international agencies. I would like to provide you with a brief message in this line of sustainable, resilient social security systems. And at the beginning of the pandemic, the countries in Latin America and the Caribbean are facing a regional landscape which is very complex, which is not only present during the pandemic, but also is in the midst of a high uncertainty, economic uncertainty. And one of the main lessons is that without social security, it's not possible to think of inclusive social development and also thinking of sustainable development. In that sense, the countries of the region are facing the great challenge and historical opportunity to face the great structural weaknesses of our social security system and protection, the social protection systems, and we have finally gone back to decades of inequality and deficit of social cohesion which affect the region. The panels of this regional seminar focus on challenges faced by the pension systems as well as the health system as today. And in relation to pension system, there is a consensus in terms of the need to consolidate a universal pension system, the principle of social solidarity, equality, going towards sustainable pensions in terms of coverage, the benefits, financial sustainability. And another thing that was a matter of debate is that it's not a one single model for the region, but for decades after the introduction of individual capitalization, the concentration of efforts, the pension fund, especially individual saving, is a policy has not provided the expected result in terms of improving coverage of the services and the region, different from the reforms in the last century during the 90s, has over the last 15 years been getting apart from the individual capitalization and implementing systems funded by public funding, promoting design of mechanism, promoting solidarity. We put in an order to the pension fund systems in regions. So there is the need to advance to design where the collective approach is strengthened and increase exchanges and knowledge about these collective mechanisms to face amidst of sustainability, the objectives of the pension systems. Is necessary to advance in the articulation of contributed and non-contributed elements of these systems together with basic benefits, going to growing elements of equality. And another thing in terms of structural reforms that was discussed also in this seminar is that these structural reforms have different impact, and it's important to consider in the design of a pension system to mainstream gender. At the same time, in the health area, the pandemic of COVID-19 has surfaced the need to make progress towards a universal, comprehensive, and sustainable systems, revealing the weaknesses of the structural system, which provide which are demonstrator of a chronic weakness with segmentation and aspects which are not comprehensive, and the fragmentation in terms of organization and care, the position and debates that were held today make us to recognize the need to increase investment in health to overcome inequalities that persist in other countries which have gone deeper because of the pandemic. The pandemic has triggered many impacts on the social crisis is there. The pandemic also has provided opportunities to put at the core of the political discussion health. But so there is an important a possibility to advance in the health systems, to allocate more resources, investment in health, with a view to make progress towards a universal, comprehensible, resilient, and sustainable systems. So we can ensure the need to consolidate welfare state, social rights, to make progress, to sustain this social protection, universal social protection, with a basis of inclusiveness contributed in the midst of equality. As Professor Barr said yesterday, within a context of high uncertainty, the state of welfare is essential, which not only intervenes in poverty alleviation and reduction of social exclusion, but also plays a key role in terms of the efficiency and equity in the middle of a market. And so the need to make progress towards a state of right, a welfare state, strengthening is urgent.
So the importance of achieving political contributions with a social intergenerational pact that will provide certainty for the policies that are required in pensions and health in order to guarantee and implement sustainability, financial sustainability of social protection. That social pact needs a new tax or fiscal pact universalizing social protection vis-a-vis the risk matrix, allowing to move forward and with an intergenerational perspective so as to include sustainable development with equality. And to finish, just like ECLAC has said on several occasions, we reiterate the need of leveraging this window of opportunity as a result of the pandemic and crisis in order to be a transformative process promoting social inclusion and guaranteeing financial sustainability for social investment that in order to finish with inequality. Thank you very much, Mr. Alberto Arenas. I think you have made a very complete summary of conclusions these days, recovering central elements both in pensions and health. And these, in this final panel, it has been clearly stated with all the most salient comments of this dialogue. Now, Mr. Felice Saqueo, I think that is in the format of a pre-recorded video. Can you? Yes. Good afternoon. It's an honor for me to greet you within the second regional seminar of social development, this closing panel. A special thanks to ECLAC for the organization of this seminar, jointly with ILO, PAHO, German Cooperation, and the Regional Program for Development in Transition Development, supported by EU, jointly with ECLAC and OECD. The pandemic of coronavirus altered strongly the lives of our societies. This unprecedented crisis and multiple devastating effects have evidenced the deep inequalities and the important coverage gaps existing in the region for achieving integral, comprehensive social protection systems. For that reason, this seminar is especially timely and offers a valuable space to share thoughts on the need and the potential for strengthening social security systems in the region. Social security is a piece of social welfare states in Europe, a fundamental pillar of which we are very proud in Europe, and that in spite of its ups and downs, it has guaranteed production and protection to the population, being a great factor for economic development. The efficiency of equality. European Union has been for more than 15 years collaborating with Latin America to strengthen social cohesion and fight against inequalities. For example, in our insignia program, Euro Social Plus, that has created a solid space for bi-regional dialogue, the learning among peers, and the transfer of successful experiences in promoting public policies. So, through it, the EU has supported different reforms for the improvement of pension systems and health in Latin America. So, I'd like to underscore that right to health is key for sustainable development, for better quality of life, and the well-being of everyone. The pandemic has has evidenced deficits of health systems. First, the universal access and efficacy and resilience of health systems mark the perimeter and are central elements of our cooperation in this field. That includes investment in assistance health staff, promoting digital health services, and addressing inequalities. Secondly, a subject of autonomy of countries in key issues like vaccines, pharmaceuticals, and supplies. As the representative Jose Borrell said, COVID crisis has demonstrated how health could become a geopolitical issue. Face masks or antibiotics are not strategic products in themselves. However, when produced by a small number of countries that are strategic potential rivals, do become strategic products. Both Europe and Latin America need to diversify its supply sources, and in this, they can be allies. Thirdly, you need reforms and investments in health systems in order to increase resilience and management capacity of present and future crises. Within this framework, recently, in the month of June, Ursula von der Leyen, President of the European Commission, and Pedro Sanchez, President of Spain, have implemented a new association between European Union and Latin America and the Caribbean for the local manufacturing of vaccines, medications, and other health technologies, and the reinforcement of resilience of health systems. No doubt that this initiative will strengthen even further the social, economic, and scientific links in our region. Fourth and lastly, an area that calls for special attention is that of care of elderly dependent persons. Also, cooperation from Europe and Latin America can be very useful. That has a very interesting pillar, the Euro-Social program supporting policies of assistance as the network of care and policies of care for that has been promoted by Eurosocial, IDB, French Agency of Development, and that emerged with the purpose of accompanying development policies and processes of national care policies through the exchange of experiences, knowledge, and mutual support. I would like to highlight that the region of Latin America and the Caribbean already has a tremendous trajectory of support to social protection, even in difficult times, like, for example, during COVID-19. Data of Latin America and the Caribbean show that 2/3 of the population are covered by at least a system a regime of 45%. Thus, the spending in social protection would 17% be above the average standard of 12% of GDP. There is a variation given that some countries invest less. In spite of advances looking into the future, it's necessary to improve the integration of social protection systems horizontally, covering gaps of coverage and guaranteeing service provision. Therefore, countries should consolidate universal social protection systems that are financially sustainable. At the same time, the countries of the region should make sure that any measure of austerity as a result of world crisis underway, COVID-19, will not reverse or stop the systems of social protection. So as to overcome those challenges, our ambition is to move to a new generation of programs in the social that will support our bi-regional dialogue on human development, now with the broadened reach, including also the Caribbean. The characteristics must be concentrated in health, education, women, youth, and at the same time, the roots of social inequalities are still addressed. Likewise, the European Commission continues supporting programs addressing the development of employment policies and social inclusive protection systems. The Social Plus program offers a technical cooperation mechanism among public and agents that have supported in Antigua, Barbuda, Argentina, Barbados, Brazil, Colombia, Haiti, Mexico, and Peru, particularly on the reforms of pensions and the issue of coverage of informal workers. We continue working so as to ensure the efficacy of social protection. In 2024, we will undertake a new global program called Universal Social Protection 2030, designed to create a social protection integrated and interoperable social protection systems. It is a great opportunity to collaborate with the Latin American countries as there are experiences and more advanced systems. And to conclude, I think that it's important that we continue reflecting on how can we reinforce social protection integral systems, its financing, and ensure systems that allow for solidarity in taking into account informality, inequality. I'm certain that this seminar that has brought together representatives totally convinced from both regions will allow to set up a fruitful basis of ideas to feed dialogue and thus reinforce the association of the European Union, Latin America, and the Caribbean and open the way for inclusive development. We have heard the words of the representative of the European Commission, Mr. Felipe Saquel, and very important words.
Importancia de la cooperación entre América Latina y el Caribe y la Unión Europea en el tema tan importante para el desarrollo sostenible y para un desarrollo inclusivo, como es el tema de fortalecer la protección social. Pasamos a las consideraciones, ¿no? O la intervención del señor Manfred Hebe. Também entendo que há video pré-gravado. Adelante.
Muy buenas tardes a todas y todos. Un saludo especial a nuestros queridos amigos y socios de la CEPAL, especialmente al equipo de la División de Desarrollo Social, a las y los representantes gubernamentales, de la academia y de la sociedad civil. Queridas y queridos participantes. En primer lugar, quiero expresar mi agradecimiento por la participación de todas y todos los panelistas que enriquecieron el segundo seminario regional de desarrollo social, seguridad social y la crisis prolongada, una oportunidad para combatir la desigualdad en el marco de un estado de bienestar en América Latina y el Caribe. Una de las lecciones que dejaron las presentaciones y debates del seminario es que enfrentamos grandes desafíos para la realización de un estado de bienestar en la región, entendiendo por ello la existencia de sistemas de protección social y de salud universales, integrales, sostenibles y resilientes. Pero no solo para los países de la región significa un gran desafío, sino que también para aquellos países que son considerados ejemplos de un estado de bienestar. Hoy, igualmente enfrentan grandes desafíos para mantener la cobertura y calidad de los respectivos beneficios para sus ciudadanos. En el contexto de la protección social, el futuro de las pensiones representa hoy sin duda uno de los temas de mayor relevancia para los países nórdicos. A eso se suman otros desafíos como la migración masiva y
So on top of that, we have challenges such as massive migration and the future in a labor world influenced by all these factors. Social protection as a right and as a fundamental basis for a welfare state has as a counterweight to the need for sustainable financing. And this is where we find aspects such as fiscal policy, the redistribution of resources, and innovation and quality of work that should enable sufficient revenues in a sustainable fashion. And there is no doubt that there are no magic recipes to resolve this that often make place decision makers and public policy designers with a dilemma, even more so within a global context that is very variable. Even facing the effects of the COVID-19 pandemic today, we find an additional challenge for national economies, but also for the international community. The possible impacts of the war in the Ukraine is something that we cannot yet view as a whole for our region, but we already find that many economies face a complex scenario. High levels of inflation and a significant increase in fuel and fuel prices and basic product costs, and that endangers social peace and democracies. At the same time, the reaction of the international financial system also has an impact on the budgets of many countries in the region, and thus the possibilities of financing social protection measures. The present scenario seems to indicate that the paradigms that existed during the 20th century and the beginning of the 21st century have come to an end. We need new ideas. We know that there won't be any perfect solutions to overcome these crises. Each country has to face them considering its own context, but we know we have learned lessons and experiences that need to be shared in order to facilitate decision making within this complex scenario. And this is where I feel what is fundamentally important is the work of ECLAC, as we saw during this seminar. As a German cooperation, we are happy to be able to support and enrich the exchange and discussions about the design and implementation of public policies that are substantial for the region. And of course, we hope to continue to make a contribution. Thank you very much once again for the team of social development team and all participants that have contributed to enrich dialogue and the debate of ideas. Well, these were the words of Mr. Manfred Hebig, representing German cooperation, a fundamental partner, as well as the European Union for this second regional seminar. And this highlights the importance of the support of international cooperation and the alliance between alliances, funds and programs of the UN system, so that we may discuss such a fundamental issue for sustainable development. For the ILO, undoubtedly, it has been an honor and a tremendous satisfaction to accompany this second seminar with direct participation of various colleagues. And in that sense, I would like to thank ECLAC for leading this joint initiative and the PAHO for also forming part of this initiative. And hopefully, we will be able to continue to work in collaboration as part of the UN system in favor of social security in terms of pensions, in terms of health, and of course in terms of universal social protection, both in its horizontal dimension and vertical dimension, in order to ensure greater welfare for the population of Latin America and the Caribbean. So, Alberto, I once again thank you for your leadership of this ECLAC initiative. We are very happy to have been able to form part of this, and I would like to offer you the floor so that you can finally close this cycle, this second regional seminar. Thank you. Thank you very much, Leonardo, for this, for acting as moderator in this closing session. These have been three very intensive days with profound collaboration and debate, involving a very interesting and important debate. And this highlights the importance of social security during these moments of crisis and uncertainty. And I believe that in that sense, what has been very valuable this has been very valuable. I would like to thank the cooperation of the ILO, of German Cooperation, of PAHO, of the Facilities Project of the European Union. And we have concluded the second regional seminar on social development. We're very happy. And we already see 103 participants online. And so they have revealed a very important level of patience. We would like to thank you all, the countries that were present, the authorities of countries. We have had a coverage with international entities and with countries where this is indeed an issue that calls the attention of many people and is so necessary in order to advance towards a strategy of facing up to inequality in the region, so that we can reach inclusive social development and a development that is indeed sustainable with equality. So I say farewell to all of you. Thank you very much. And once again, I'd like to thank the whole team of the Social Division, Social Development Division of ECLAC that have enabled this event. Thank you very much, and see you next time. Thank you.
Muchas gracias a todos y a todas, también al equipo de intérpretes, ¿no? Que se ha quedado hasta ahora. Gracias.
Gracias.
Luego, gracias.
Simone, muchas gracias. Berta, por favor. Muchas gracias.
Hasta luego, Berta.
Muchas gracias. Leonardo, muchas gracias y un gusto. Gracias.
Ahora estoy acá, cita Nancy. Así que eso
Hola. No, don Jorge, muchísimas gracias por todo. Muchas
de nada,
gracias.
cita Claudia.
Gracias por haberse quedado hasta esta hora y mil gracias por todo.
No, no se
Ahí
preocupe,
estamos.
eso estamos.
Gracias.
Cuídense,
Chao.
que tengan un buen retorno a casa.
Gracias, igualmente.
Muchas gracias, que estés bien.
Gracias, cita Nancy. Nos vemos.
Nos vemos, chao.
Gracias a los intérpretes, si es que aún están por ahí.
Gracias, Jorge.
Gracias, Marquito, que llegues bien.
Igual, cuídese.